Welcome, everyone. Ladies and gentlemen, good evening, and welcome to the fourth edition of Health Vision 2030 Forum, organized by Bahrain Specialist Hospital for the year 2023. My name is Sarah Riyadh, and I'll be the host for this evening. Before we start, please make sure that you register by scanning the QR code or at the registration desk near the entrance, as it's required for your certificate. Today's conference, Health Vision 2030, New Frontiers in Cathlab Intervention, is being held under the patronage of His Excellency, Lieutenant General Dr. Shaikh Mohammed bin Abdullah Al-Khalifa, the Chairman of Supreme Council of Health. On behalf of Bahrain Specialist Hospital, I would like to take this opportunity to extend our gratitudes to His Excellency for the patronage of this conference. Before we get into the most awaited session of this conference, let me introduce the chairperson of this evening, as well as our expert panelist and moderator, who shall present their perspective on the topics through conversation engagement and also by answering your queries and questions. The chairperson of this conference, who is also the vice chairman of Bahrain Specialist Hospital, consultant, gastroenterology and internal medicine, Dr. Najah Rashid Al-Zayani. Our first panelist for the evening is Dr. Mudassir Shah. He's a sharp-witted interventional stroke neurologist with extraordinary clinical insight, and he has more than 10 years of experience in the field of neurology and interventional neurology. He has worked with many organizations in this field in India and abroad. Our second panelist is Dr. Prashant Bakar. He is a consultant cardiologist with 16 years experience in handling cardiac emergencies. He is also an active member of the European Association of Cardiovascular Imaging. Now coming to our moderator, Dr. Shaikh Baks. He is a senior interventional cardiologist with over than 10 years of experience. He is an expert in a wide range of cardiovascular conditions, including complex percutaneous coronary intervention. To start, I would like to call up on stage the Vice Chairman of Bahrain Specialist Hospital, Dr. Najah Rashid Al-Zayani, to deliver her opening speech.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank Sheikh Mohammed for his patronage of this important conference. I would like to thank you all for attending this important event tonight, which will allow us to celebrate the successes and performance of our esteemed cardiologists and cardiovascular services. It is clear that in our modern day, as the shift from diseases like infections, which shorten the life of people only a century ago, is shifting towards more complex diseases in the form of cardiovascular, neurovascular, and oncology cases. The improvement in the standards of living and the presence of higher expectation of life mandated that we see more of these diseases and concentrate our efforts to try to save the lives of young and middle-aged people who are suffering with myocardial ischemia, cerebrovascular ischemia, or cancer cases. As you know, with higher standards of living, there comes more risk for these diseases, including sedentary lifestyle, abundance of processed food, stress in life, and competition. And these all led to a massive epidemic of obesity in Middle East. This obesity epidemic will have many consequences, not only for our present population, but for the future of this area. I'm very proud to say that our team of cardiologists, neurologists, neurosurgeon, interventional radiologists at the BSH have been instrumental in saving lives and preventing disabilities among these patients of high risk. When I came to work first in Bahrain in 1986, before many of our young doctors were even born, I had to meet the situation of dealing with my own relative who suffered an MI. I had to take care of this person, and I had no access to cardiac lab, no intervention, and I saw him losing part of his myocardium with deterioration in his heart function. I couldn't do anything. I did not have access to interventional lab or even to electrophysiologist in case he went into heart block. Things have drastically improved in the last few decades with the presence of very advanced cardiovascular surgery, initially at the BDF, now at Khalifa bin Mohammed Center, and now at the Bahrain Specialist Hospital. We're very proud to be working in tandem with the public services to provide access to the best cardiovascular treatment available worldwide. This is one dream fulfilled, but I have many other dreams to fulfill. One of them is to make our hospital a teaching center and to improve the quality of healthcare and set a standard and teach our future generation of doctors and nurses how to handle these complex cases. In addition, recently, neurovascular and neurosurgery has been established at the Bahrain Specialist Hospital, and I'm very proud to say that neurovascular intervention and advanced neurosurgery procedures will be a big field to cover in our area, and I hope that they will be as successful as the cardiac surgery and cardiac disease center. Our interventional radiologists recently who joined us can also extend help to patients with extra cardiac vascular diseases like mesenteric ischemia, peripheral vascular disease, and carotid disease. I'm therefore very proud to say that now we have a comprehensive unit which will deal with the events of ischemia, be it in the heart or in the peripheral vascular system or in the central nervous system. It's not only important to save lives, but it's important to educate the population and educate them to the risk factors that lead to these diseases. So I'm also very proud of our metabolic team. Dr. Maher from Diabetes Clinic has been working hard to prevent development of obesity, diabetes, and metabolic syndrome. We're working hard in the GI clinic to give support to the services and detect NASH and detect these diseases relating to obesity. I'm also very thankful for the Apollo services who gave us great support in establishing the cardiovascular system. And I would like to wish their chairman, Dr. Pratik Reddy, a happy 90th birthday. This week is his 90th birthday. This man has been a role model for me, where he came back from the States as a young physician and established advanced cardiovascular surgery in his country decades ago, and now he is running the most advanced cardiovascular units in India. These people should be examples to our young physicians who go and study in the West to come back and populate their area with the best medical skills rather than criticize what is there. Deliver to your population before you start criticizing. Best of luck for this conference and happy learning to all of you. Thank you.
Let's move into the heart of the conference and get introduced to our speaker by our moderators. May I ask the moderators, panelists, please come on stage.
Good evening, everyone. My name is Dr. Shaikh. I'm an interventional cardiologist at Bahrain Specialist Hospital, Apollo Heart Center, and I'm extremely pleased to have the opportunity to be the moderator of today's evening. Friends, today our theme is New Frontiers of Cathlab Interventions, and we have an exciting series of talks lined up for this purpose. So I take this opportunity, and it gives me immense pleasure to invite our first speaker, Dr. Adel Khalifa. Dr. Adel Khalifa needs no introduction to all of you. He is very famous and well known to you. But for the sake of today's evening, let me say his profile. Dr. Khalifa is a consultant interventional cardiologist and cardiac electrophysiologist, and he heads the Department of Electrophysiology at Mohammed bin Khalifa Al-Khalifa Cardiac Center. Dr. Khalifa joined Mohammed bin Khalifa Cardiac Center in 2008. He specializes on cardiac devices, arrhythmias, general and interventional cardiology. He is also an examiner at the Arab Board of Cardiology. He will be speaking today on left bundle branch pacing, current knowledge, and future prospects. Please welcome Dr. Adel Khalifa with a big round of applause. Dr.
Thank you, Mr. Chairman. Good evening, ladies and gentlemen. First of all, allow me to thank Bahrain Specialist Hospital for their kind invitation. It's indeed my great pleasure and honor to be here 2 years in a row in this very interesting Health Vision 2030 forum. So can you see the slides? Where are the slides? Okay. Yeah, no, it's there. Okay. Yeah, it's there. Yeah, it's there. Thank you. So before I proceed any further, I would like to share with you my disclosures, but I don't have any disclosures relative to this talk. So cardiac pacing and pacemakers have revolutionized our modern medicine. And cardiac pacing and pacemakers, they have a very interesting history that goes back to almost 100 years. And for the sake of time allocated to this presentation, I will give you a glimpse of the biggest milestones in this field. So the first wearable transistorized pacemaker was invented in 1957 by Packen, who was an engineer. And these pacemakers, they were actually wearable on the neck, and they are actually connected to the wall socket as a source of energy. So when the energy is out in the patient's room, the pacemaker will stop working. But the true first implantable pacemaker was founded in Solna in Sweden in 1958 by Dr. Ron Elmqvist with the help of a famous surgeon at that time called Senning. And the patient actually was 43 years old who had a complete heart block at the age of 43. He managed to live another 43 years. So he died at the age of 86 for non-cardiac issues. Believe it or not, during his lifespan, he had 28 pacemakers. So this is quite very interesting as a pioneer and pacemaker implant. So since then, we've seen a tremendous advancement in the pacemaker technology, starting from smaller number of size when it comes to the pulse generator. In the old days, the pacemaker was weighing more than a quarter kilo. I have it actually here. Mohammed, can I just? These are not real pacemakers, but when the pacemaker came, that was the size of pacemakers, and they are weighing more than a quarter of a kilo. Nowadays, we do have pacemaker of this size, which is the leadless pacemaker. So this is really a revolutionized milestone in modern medicine. Also, we've been seeing a lot of changes in battery longevity. The original pacemakers, they were lasting for a few days. And then with improvement, they've been lasting for a few months to years. Nowadays, pacemakers can last up to 14 years. Pacemaker features also another area where there is an intense development. The original pacemakers were simply a box. You cannot really program anything. Nowadays, most of the pacemakers are automated. They have a Bluetooth technology, and they have a lot of features which is really convenient for patients' care. Pacemaker site also have been evolved, and this is my core topic. We will talk about it shortly. And before I actually end up this introductory slides, I would like to mention that also part of the evolution of pacemakers is remote monitoring. Nowadays, we have the capability of checking pacemakers from the comfort of patient's home. We are able to interrogate the pacemaker and record all the parameters while the patient at home, And if there is anything abnormal, we can call the patient and we can ask him to come to the hospital for another assessment. So pacemakers are a very effective treatment for a variety of bradyarrhythmias. And I will promise you in this talk, I will not really talk too much about technical issues because it might not be of an interest to everybody here. So pacemakers, actually, they were very effective in the treatment of bradyarrhythmias. And traditionally, we were using the right ventricular apex where we put our pacemaker lead, as you can see in the diagram. But then with time, we found that pacing the right ventricle can lead to electrical and mechanical desynchrony. And this is actually was proven by one of the older studies, which is called the MOS study, where patients, they were randomized to either dual chamber pacemaker versus single chamber pacemaker. And then the study where substratified patients based on the cumulative percentage of pacing into 4 groups, those who paced less than 10%, 10 to 50, 50 to 90, and more than 90%. So guess what happened? So those who were pacing more, they have higher risk of developing heart failure and atrial fibrillation. And there was no difference between the dual chamber pacemaker and single chamber pacemaker when it comes to heart failure hospitalization. However, the risk of AF seems to be more in patients with single chamber pacemaker. This is a similar slide showing the Kaplan-Meier curve related to the freedom from heart failure hospitalization and AF. And as I mentioned, the more pacing, more apical pacing is there, the higher the chances of heart failure and atrial fibrillation. So, so it seems that the RV apical pacing is not working as it should be. So we were thinking of new and different sites. So what we've done, we chose a different site for pacing, the RV septal pacing, or the right ventricular outflow tract, as you can see in the diagram. And the septal pacing and RVOT pacing, we call it non-apical pacing. So now we have the traditional apical pacing and we have the non-apical pacing. So did we do better with the non-apical pacing? Well, let us see the literature. So there are actually an analysis of 12 studies comparing the apical versus non-apical RV pacing. Most of these patients included in this analysis, they have heart failure and they have wide QRS. 2/3 of them, they have left bundle branch block, and basically all of them, they have ejection fraction less than 30%. Now, when it comes to the results, we found that there is no difference between apical pacing and non-apical pacing when it comes to changes in the left ventricular end systolic volume. Similarly, when it comes to the functional class, there was no improvement between apical and non-apical pacing in terms of NYHA class. Finally, when it comes to all-cause mortality and cardiovascular hospitalization, there were 4 studies that address this question. 3 of them did not show any difference between apical and non-apical pacing when it comes to all-cause mortality and CV hospitalization, while only 1 study have shown that there is 50% reduction in all-cause mortality and CV hospitalization. But keep in mind that this study was underpowered to determine superiority of either one approach over the other. So the conclusion, still non-apical pacing, septal or RVOT, they are not as we hoped they will perform. Still, some people believe that septal pacing or RVOT pacing is better than apical pacing, but the literature is not robust. CRT, cardiac resynchronization therapy using PIV pacing, is another indication for pacing for the treatment of heart failure. It's a very useful intervention. We know that CRT reduces morbidity and mortality in patients with HFrEF, it improves exercise tolerance, and it promotes left ventricular reverse modeling. However, also CRT, they can have unfavorable effects. One of them is that the non-responders can reach 30 to 40%. Furthermore, the IV pacing also is non-physiologic, meaning it requires 2 leads to activate the ventricular myocardium and not the specialized conduction system. So in our search for an ideal site for pacing, we found that Hess bundle pacing or pacing the native conduction might be of value. And Hess bundle pacing directly stimulates the physiologic conduction system. And early studies have shown that there might be better outcome compared to RV pacing. And potentially, the Hess bundle potentially easier to implant than LV pacing lead in CRT, but obviously it is more difficult than conventional dual chamber pacemaker. And the Hess bundle pacing can be either selective or non-selective. And I promise you I will not really go into details. And one of the studies that looked at Hess bundle pacing found a very interesting observation. This patient, for example, he underwent a Hess bundle pacing, and what we found after 8 months, that the systolic diameter of the heart has reduced from 60 millimeter to 50 millimeter. The diastolic size of the heart has reduced from 66 to 60 meters, and the ejection fraction improved by from 10 to 30%. So these are really a remarkable improvement in an experimental approach for pacing. Dishmoch, he did actually another study on 18 patients. These patients, he did Hess bundle pacing. And as you can see in this slide, there was a significant improvement in terms of left ventricular end systolic and end diastolic diameters, in addition to improvement in ejection fraction. Furthermore, the cardiothoracic ratio significantly reduced in patients following Hess bundle pacing compared to conventional. There are actually at least 19 studies on Hess bundle pacing, and I'm showing only 8 or 9. And all these studies, although they are a small number, but all these studies have shown that there is an improvement in ejection fraction and functional class in addition to QRS narrowing. The Hess alternative study and the Hess sync trial have shown also that the result of Hess bundle pacing is comparable to CRT, but it is not really superior to PIV pacing. So what are the indications for Hess bundle pacing? First, to prevent RV pacing-induced cardiomyopathy in case of ventricular resynchronization in patients with left bundle, in heart failure and AF, and lead to AV nodal ablation, and heart failure with narrow QRS complex. The downside of Hess bundle pacing, and that's why actually many implanters probably they stopped doing Hess bundle pacing for various reasons, although the literature initially was favorable. But the problem is it is difficult to implant. This is one thing. Lower success rate in those with wide QRS, high pacing threshold, and this is a major issue, in addition to unstable lead, which leads to lead dislodgement either acutely or subsequently. So since we are not even satisfied with Hess bundle pacing, we moved for something else. We were concentrating on the native conduction system of the heart. So we searched and we said, well, you know what, there is the left bundle. So let us actually pace the left bundle and see if we can have a better outcome. The left bundle area pacing is defined as capturing the left bundle along with LV septal myocardium at a low output, which is less than 1 volts at 0.5 millisecond pulse width. Again, I'm not going to bore you with the technical aspect of this, and there are different variations in the implant procedure. Some actually implanters, they do echo or MRI prior to the procedure to estimate the thickness of the septum and to look for scars of any. Two companies, they are actually doing special sheaths and leads for bundle branch pacing, including Medtronic and Biotronic. The crucial aspect of this procedure is to localize the Hess area, and this can be done with a dedicated quadripolar catheter. This is the implant technique, and I'm not going to details, but the importance of this slide is that as we approach the septum, we have to look at the intracardiac AGM because it will give us a clue whether we reached the left bundle or not. Starting looking at the surface ECG in V1, we look at the inverted M shape or the W shape. And as we advance the helix or the lead toward the septum, this W pattern, if you can see it here, will be lost and we will have an RV wave until completely we have a right bundle pattern indicating that we reached the left bundle. Furthermore, in 30 to 80% of patients, we might lucky to see a left bundle signal there. And also, once we are really at the left bundle area, we can measure the left ventricular activation time, which should be very fast. So let us look at the clinical outcomes of left bundle branch pacing. Now, the first actually study or the first case report came from China. And surprisingly, the Chinese, they have the largest number of cases of left bundle branch pacing. And in their actually registry, they accumulated at least 5,000 cases. Unfortunately, all these cases are written in Chinese, so I don't have the literature to review them. So the first case, which was published at the Canadian Journal of Cardiology, a 72-year-old female with dilated cardiomyopathy and EF of 32%. She has NYHA class 4, and baseline ECG showed a very wide left bundle at 180 milliseconds. This patient failed medical treatment and failed LV lead placement, and subsequently, Huang actually, he tried to do his pacing, which failed, and then he ended up doing left bundle branch pacing. So at 1 year follow-up, what did he find? First of all, the ejection fraction had improved from 32 to 62%. LV end diastolic diameter had reduced drastically from 76 to 42 millimeter. NYHA class had increased from 4 to 1, and serum BNP had reduced also, and the cardiothoracic ratio has decreased also from 67 to 55%. These are really a significant sort of numbers for a novel approach to pacing the native conduction system. Also, if you look at other prospective study have demonstrated that permanent left bundle branch pacing is feasible. So although the number of these studies are small, but the success rate, as you can see here, ranges from 80 to 94%, and there is always a learning curve. And surprisingly, that the paced actually QRS after left bundle pacing is very, very narrow with a very little sort of complication rate. In the MELOS study, which is the multi-center European left bundle branch area pacing outcome study, which was prospective, multi-central registry, there were 2,500 participants in 14 European centers. This registry have found that the left bundle branch area pacing is feasible, and the success rate is almost 92% for bradyarrhythmias and 82% for heart failure. And the overall lead complication rate is roughly 8%. I don't know how much time I have. The next 4 slides, actually, I compare the left bundle pacing with BIV pacing or CRT. If I have 5 more minutes, I can go through these slides. So when it comes, they are different. So IV pacing and his bundle branch pacing are different. So when it comes to the anatomy, bundle branch pacing, obviously, there is a wide target zone underneath the endocardium of the left side of the septum. The IV pacing, the coronary sinus anatomy variation and venous malformation. So you have to take that into consideration. Safety. Left bundle branch pacing, safer for operators and patients with shorter operation and fluoroscopy time, while IV, obviously, it's a longer procedure and it requires more X-ray exposure. When it comes to cost, bundle branch pacing, obviously, relatively cheaper compared to IV pacing. And when it comes to technical difficulty, bundle branch pacing is relatively easier compared to IV pacing, which require more steeper learning curve. Delivery tools and leads, bundle branch pacing limited, while IV pacing, there are numerous. And this is not really surprising because IV pacing have been in the market longer, and there are much more studies on IV pacing compared to bundle branch pacing. Success rate, more or less comparable, maybe slight edge for bundle branch pacing. Response rate, it's not clear yet about bundle branch, what we have at this point, some case studies and some prospective studies, a small number. The IV pacing, the response rate is 70%. Okay, so what are the clinical implications of left bundle pacing? So basically, bundle branch area pacing has more chance for correcting the distal conduction compared to his bundle pacing. Bundle branch pacing is emerging as an excellent alternative to IV, and improvement in ejection fraction was noted in both ischemic and non-ischemic patients undergoing this type of procedure. Everything good comes at a price, and the price of left bundle branch pacing can be variable, including septal perforation, septal artery injury, right bundle branch injury, lead dislodgement, and thromboembolism. In addition, and this is my last slide before the conclusion, there are still a lot of things which are unknown about bundle branch pacing. Remember, although it's not completely new, but still we don't have robust data on the effectiveness and the utility of bundle branch pacing in a clinical practice. So I will leave you with these queries and questions. What is the long-term safety and efficacy of the procedure? We don't know. How can we accurately determine the depth of the lead implantation to avoid occurrence of septal perforation? We don't know. Some actually studies, which probably I skipped by chin, they've been actually using intra-procedural echo to determine the length of the helix when it perforates the septum, and to look if there is actually perforation or not. Will the risk of thromboembolism and lead dislodgement increase? We don't know. What is the long-term effects on interventricular septum and left bundle branch when they are traumatized by the screw on the tip of the lead? Can a second bundle branch pacing lead be successfully placed if the earlier one fails? What is the impact of bundle branch pacing on arrhythmias? Can we actually, down the road, can we remove or explant a left bundle branch lead? We don't know. So these are all really unknowns, but I guess these questions will stimulate the scientific community to provide more studies and more answers. So in conclusions, ladies and gentlemen, left bundle branch area pacing is a novel pacing modality that can bypass the pathological or disease vulnerable region in the cardiac conduction system to provide physiologic pacing modality for patients. Left bundle branch pacing guarantee a narrow based QRS complex and fast left ventricular activation time with a low pacing capture threshold. 3 previous studies have shown that left bundle branch pacing can be applied to circumvent the limitation of his bundle pacing or RV pacing and can be a replacement for probably CRT. The future studies are expected to validate bundle pacing safety, reliability, and long-term performance using larger trials and affirm its potential as an alternative for physiologic pacing. Thank you very much.
Thank you, Professor Khalifa, for your excellent presentation on left bundle branch block pacing, which is an exciting prospect in the field of cardiac pacing. Moving on, it's my pleasure now to invite our next speaker, Dr. Mohammed Balghith. Dr. Balghith is a stalwart in the field of interventional cardiology and a leading figure and a prolific operator in the field of structural interventions. He has been appointed as co-editor of European Heart Journal, and he serves as the ACC Governor, Saudi Arabia chapter. He's a professor, King Saud bin Abdulaziz University of Health Sciences, College of Medicine, consultant, adult interventional cardiology, King Abdulaziz Cardiac Center, Ministry of National Guard of Health Affairs. He was a former vice president of Saudi Heart Association, head of International Collaboration of Saudi Heart Association. He was a program director of fellowship and residency training program in cardiology at King Abdulaziz Medical Center since 2001 to 2008. And he served as a director of Cathlab in King Abdulaziz Cardiac Center from 2008 to 2013. He was representative of cardiac sciences in pharmacy and therapeutic committee at King Abdulaziz Medical Center from 2001 to 2007. He has written prolifically in multiple national and international journals, and he will be speaking today on advances in structural heart disease. Please welcome Professor Mohammed.
Assalamu alaikum. Good evening, ladies and gentlemen. And it's a pleasure to be here in Bahrain. Just I came from the airplane to the meeting. I haven't even checked my room, but I'm so happy to see all the faces I know here. And you know, the electrophysiology, they are booming nowadays, and they are our colleagues in the Cath lab. Sometime we fight with them for the slots. There is a real advances in structural heart disease, and I think when we think about structural heart disease, it's mainly we think about the valve. And one of the major diseases we have in our old people, and luckily enough, our population getting older and older. And when I was in Cedar Sinai in one of the special visits, actually I discovered they bring their aortic stenosis patient from the long-term or extended care unit. They go and they auscultate them, and you know, they don't do a lot of work there, but it is a severe AS. They bring them to Cedar Sinai and they include them in the research. In our society, I think it is common, and some of the people, they came into the hospital for the first time, either as a syncopal attack or a chest pain or a heart failure. And one of the referrals or how they get into cardiology, it's not visiting the cardiac unit. They come in for another disease like knee replacement. And by chance, somebody put a stethoscope and he found the murmur. And then the anesthesia, he will say, I will not touch this patient till I get approval from cardiology. Elderly people with aortic valve stenosis, especially severe, most of them, they will be symptomatic. But what we learned since we started the program of TAVI, for example, in 2010, actually, in November, and we are at least in our hospital, we were putting patients on the waiting list, and we discovered that some of them died while they are on the waiting list. And then we thought about the discussion before with the ECHO people. One of our leaders, he was in Saudi, is Dr. Ahmed Amran. He's originally from Iran. And he used to tell us, this is a bad disease. Don't leave your patient. Just do it if you can. And when we think about it, it is a present disease. People who have aortic stenosis don't always have symptoms, as we mentioned. And the three typical symptoms, either shortness of breath, dizziness, chest pain, or faint, That's why the aortic stenosis is a life-threatening and progress rapidly. Whenever you diagnose your patient with aortic stenosis, their survival will be compromised. And survival after the onset, we know this from the research, of symptoms is 50% at 2 years and 20% at 5 years. The TAVR started in 2002 in France by Al-Khalifa, and most of the hospitals in Europe adopted this. And I think the American, they start with research before they make it a real practice. In the Middle East, we followed the European. We started the program earlier than some centers in the state because they were only in trials. And I think we built a good experience in the Middle East. Like Turkish people, they were the highest in number because of the population. Then I think Saudi nowadays, Egypt is getting there because they get some way to pay for those patients. It's a very expensive device when we talk about transcatheter aortic valve replacement or TAVI. It is not a single, or it's not a cheap device. And when we started, we prepared the patient, we diagnosed them by echo, then we studied them by cardiac CT scan. And the device was big, like the sheet was about 24 French, and you need a big vessel to go there. Nowadays, there was a lot of competition in the technology, and they are down to 14 French, which will be compatible with a 5 millimeter size artery. When we talk about aortic stenosis and intervention by TAVI, the priority is very important. You could have two people same age, somebody is frail and somebody is in a good health. And this is this assessment is started from the surgical point of view. Now it's in the same field in the cardiology, at least at the interventional point of view. This is the first case in the whole world, which was done by Al-Khalifa in 2002 for, it was a Edward valve. And the patient, I think he survived for at least with this for 2 years after his implantation. This is the first case we did in Saudi Arabia 12 years ago. And you can see too many people, crowded Cathlab. Nowadays, only 2 operator, and that's it. Even the anesthesia now, we started with the general anesthesia, transesophageal echo, full room of people. Now, no more. Actually, we finished some cases before the echo arrived, and it's becoming very simple. Last case, I did it with even no fellow, only me and the nurse. Life is getting easy, but in the beginning, always it's very difficult. It needs a lot of preparation. You see the proctors come from Europe at that time. And this is again 12 years ago, the picture, and we were in the front and they are in the back. Aortic stenosis, as we mentioned, you divide the patient if they have coronary artery disease or not, if they are fit, and according to the CT criteria for the TAVI. And as I mentioned, the technology improved a lot, and most of the patients we screen, we will do them through the femoral artery. Very rare, we're going to do cases from the trans-aortic, like transthoracic incision, a small incision by our surgeon, or subclavian small incision. It's a hard team, as we mentioned. It's cardiovascular, like the surgeon, interventional, anesthesia, and the people in the clinic, they have to help you for screening of the patient. We went down from very invasive to less invasive or minimalistic type of practice. Again, we have 2 main companies. Medtronic started with the core valve. At least in my hospital, we start with the core valve. And we have the Sabian Edward, who are very famous, both those companies, and the surgical bioprosthetic valve. This is the Medtronic. There was a lot of changes in the technology. Now we have what we call Pro Plus Evolute, which is the latest technology. And one of the major problem we had with the beginning of the TAVI was paravalvular leak, and they managed to decrease the paravalvular leak down to trace or sometimes zero because of the sealing they put on this part of the valve, in the inflow part. And this is the Sabian 3. This is one of the most recent valves. Now we have Sabian Ultra, where they work down on the outer sealing, the skirt, to prevent the paravalvular leak. And they succeeded in that, to be honest with you. Those are the two most famous valves. Why we are adopting this? Because of the nice result and because of the nice and very expensive research done. Like partner company, when they invest by $600 million just investing the research. Partner 3 now, we went down from the high risk old age people to even low risk, like aortic stenosis more than 65 or more than 70. Low risk, they did better in comparison with the surgical intervention or replacement. If you can see in this primary endpoint, comparing the TAVI, which is the TAVI, transcatheter aortic valve replacement, with the surgery, the TAVI did better. And this is the first time. And their conclusion that in population of severe symptomatic aortic stenosis patients were at low surgical risk, TAVR using Sabian 3 compared to surgery did better, to be honest with you, significantly reduction in the primary endpoint of death, stroke, and rehospitalization by 46% at 1 year. And this was amazing results. There's still the issue, durability. We know the bioprostatic valve patient, they could have degeneration after 8 years, and still some of the good cases, yeah, they did very well up to 12 years. I remember some of them 10, 12 years, they're doing okay. With the TAVI, still, the study is going on, but we have good result up to 8 years, which is very promising. TAVI should be or soon become the first option, and I think it is there already for the majority of patients, including those at low risk for surgery. Now, the other valves, what we know about it, and most of the people here, I'm sure they know about aortic stenosis and rheumatic heart failure in the Middle East, India, Yemen, wherever, which was treated by balloon long time ago, and we're still using a balloon valvoplasty. But what about mitral regurgitation? The mitral valve, when we think about anatomy, it's a very difficult valve. It's more complicated because of the anatomy, the etiology. Again, it's different. But we are interested when we talk about mitral regurgitation about a functional or functional mitral regurg, where the new devices came and the interventionists try to compare themselves or copy what the surgeon do in the OR, the Alfieri edge-to-edge technique or repair by surgery. Then the idea of mitral clip came. And I think it started with COAPT, and even before the COAPT, the COAPT was one of the major trials where they used the mitral clip in comparison with the good optimal medical therapy. And this trial was presented in American College of Cardiology in 2019, then was presented in most of the interventional meeting like TCT, which showed a good and great result in paper of fixing the mitral regurgitation percutaneously by using mitral clip. And it's coming as a practice for us to, in patients with a high risk for mitral valve repair surgically, to fix them with the mitral clip. Then the companies start to have the same competition like the valve. And we started with the Abbott nowadays. Edward, they did a great job and they introduced the Pascal system. And here you go, where you can see a very significant mitral regurgitation here. After the clip, although the patient had BFO congenital, we did a nice puncture. We tried to avoid the BFO, And we deploy the clip, and you can see here the mitral regurgitation went down almost to trace. And this is the case before, another case before the intervention or the clip. And this is after clip. Patient, actually, one of my patients, she had the clip 3 years ago. She used to have pulmonary edema, cough every now and then. She came in just Sunday last time, and she said her cough disappeared completely. Although still some, she's old, some shortness of breath, tolerance of exercise, but at least you improve her symptoms and quality of life. It's a very expensive device again, but it's improving the life of the patient. This is the end of the procedure where you can see the clip. And as I mentioned, the Abbott was the first. Then the Abbott, they learned through the years, because we used to do like 2 clips sometimes. They make it wider now, and we are using most of the cases now. We treat them by XTW, it's wide. Same device, but make it wide. Same price, of course. Then the Edward here, they introduced the Pascal system. And the Pascal system was like you can capture the leaflet individually. And now with the G4 from Abbott, they copy the Edward. I think this competition between the company, it's good for us as operator and for the patient themselves. And if you see the age of our patient, most of them 70, 70 plus, 80, 81, whatever. This is the Pascal. It's almost the same, but little bit wider. And again, they start with a wider device, and now they are decreasing the size a little bit. The Abbott, they did the opposite, or they start with the opposite, a thin device, and they make it wider to reduce the gap. In addition to grasping, you reduce the gap of the mitral regurgitation. This TAVI also helped us when we have the periprostatic valve, either in the aortic, like previous surgical, or mitral, or tricuspid. When those valves fail, we have the solution now. We can do valve and valve. And this is, again, it's advancement in medicine. And this is one of our cases done maybe 3 years ago or 4 years ago. It was a Carpenter Edward pre-mount 33 periprostatic valve, failed like after a few years. We treat the pathology with putting a TAVI valve in the mitral periprostatic failed or degenerated valve. And this is one of the cases, the surgeon, they know those, it's a mosaic type of valve, and you see before and after, you see 2 rings, valve and valve. And again, what we do, we come from the venous side, we do a septal puncture, and if we have to dilate the septum, then we go with the new valve. And this is making our life more easier, and you can improve the quality of life for your patient. Too many cases, this is the new technology from Abbott G4, where you can see the mitral regurgitation, the 2 slides on the left side, and after deploying the new clip G4, generation 4. This is the latest they have. Sometimes you're going to have difficulty, and you have to balloon the septum, fix septum because of the rheumatic disease or inflammation in the septum. This is the mitral clip G4. This is the latest technology Abbott. This is the Edward, the Pascal system. And this is the team when they came from Europe. It's better to have proctoring from the company than you do it in your own, at least the first case or first. See the difference. See the difference. I'm sure of the surgeons here, they will appreciate how this transcatheter device or procedure improve even the result, because in the surgery they have the TEE and they do the transesophageal on the spot, and they check their result. And with this, again, those cases we do it by general anesthesia and TEE guidance. There is too many devices nowadays in the market, and there is valve replacement percutaneously, either by transapical, and it started already in Saudi Arabia, very expensive, tendine valve to replace the mitral and you go transepically, it's about 250,000 riyal per piece. And there is a valve for the replacement of tricuspid. Instead of clipping tricuspid, you do a valve replacement. Too many things in the market. This is the Tendine. I think in Saudi Arabia done about 50 cases. Again, it's mainly surgical, but the intervention, it will be in the Cathlab, but it's by the surgeon. Very small incision in the anus. And the result, beautiful, beautiful result. It's like a parachute. And this is the Evoke valve, which can be now the most of the usage of Evoke. It is in the tricuspid. Again, when they put it in the tricuspid, they minimize the tricuspid regurg post-catheter to almost zero with this type of valve. And the success rate, especially in Germany, 95%. This is from Medtronic, and it's still not in the market, but it's under trial. It is a transvenous type where you replace the mitral valve with this one. We started, this is the valve. This is the beauty of 3D imaging, where you go with it's hand in hand. You are looking for the picture, your echo people helping you. And this is how we capture the leaflet. This is before the release, and this is after the release. Again, the Sapien Ultra is a new technology also. We introduce more new technology for the TAVI now. We get Abbott TAVI on board. It's Navitor, and we get also the Indian valve, my valve, and we get from Boston Scientific American company, Accurate Mutu. At least we have 5 types of valve now in our center. One of the new devices, we are lucky we have it in the intervention, is a cerebral protection devices where you put it in the carotid when you are doing those tough cases. Sometimes you retrieve a very bad thrombus or debris, and I'm sure if those things go to the brain, people, they will end by a stroke. The Gina valve, it's an old valve. They modified it a little bit, and this is the new treatment percutaneously for severe aortic regurgitation. You talk about AS, now AI. In the UK, they did more than 22 cases so far. This is the My valve. We use it already in our centers, and I think it's a very nice valve. And this is for the tricuspid. The technology is booming. There is a new valve now in Germany called Locus or Lux valve. It's already tried for the tricuspid, and the result is beautiful. There is a trick valve. We use it in our center, but again, this is very, very expensive, and you can use it for people with a high pulmonary pressure. Okay, with the people who have a very problem or with their volume status like dialysis, and they don't do well with the clip. And what you're going to do, it's 2 pieces, comes in the cartoon, and 1 piece you will deploy in the superior vena cava, the other piece in the inferior vena cava, and it's one of the easiest procedure on the earth, but the result, it will protect the back pressure on the liver. And believe me, when you fix that tricuspid, in most of the patients, what we notice that there is a lot of improvement in their renal function, in addition to liver or less ascites than before. But you have to catch the patient earlier. This is our first case with the trick valve. Again, should be in a high-risk patient because it's very expensive, 300,000 riyal per valve. There's again new case just last week, severe mitral regurgitation. You see the MR, and this is after clipping actually. Beautiful result. The TE with the 3D, it's amazing picture. It's very nice. And this is a tricuspid clip. Again, beautiful result. And you can see the tricuspid. It's a little bit tricky in comparison with MR, but when you see the success, you will feel happy that yes, you spent some time, but you did something good for the patient. In conclusion, mitral clip therapy is FDA approval, as we say, for symptomatic patients with a severe MR of primary or mixed nowadays etiology. TAVI should soon become the first option for the majority of our patients with aortic stenosis, including those with low risk, as we mentioned. SAVR, surgical aortic valve replacement, will remain the best option for patients who are not optimal candidate for TAVI, or for the youngest patient. Age will become a key factor in the therapeutic decision in the low-risk population. Informing the patients and the relatives about the two options will be essential in the heart team decision. Thank you very much.
Thank you, Professor Balghith, for your excellent presentation on various aspects of structural heart interventions. And I'm sure we'll definitely have an opportunity to gain from your experience and expertise in future. Moving on, it's my pleasure now to invite our next speaker, our very own Dr. Amer Ardati. Dr. Amer is an interventional cardiologist at University of Illinois, Chicago. He's the director of Cathlab at J.C. Brown Veterans Affairs Hospital. He's a director of Heart Center at University of Illinois, Chicago. He's a co-chair of Emergency Cardiac Care Committee at University of Illinois, Chicago. He trained at University of Michigan, Ann Arbor, and did his residency at Duke University, Durham, North Carolina. And he did his fellowship at University of Michigan, Ann Arbor. He has been awarded with the Clifford G. Fields MD House Staff Award and an overseas fellowship from the International Institute of University of Michigan. He will be speaking on invasive management of pulmonary embolism. Please welcome Dr. Amer Ardati.
Good evening, Dr. Baksh. Thank you for that very generous introduction. Madam Chairman, thank you for inviting me, and to the honored guests and fellow panelists, thank you for sharing the podium with me this evening. Today, I want to talk to you a little bit about management of acute pulmonary embolism. And the title of this talk, When There's Something Strange in the Main PA, Who Are You Going to Call? I have no disclosures that are pertinent to this talk. And though I do have some association with Abbott and Cardiovascular Solutions. I would like to start by outlining our objectives today. We're going to review the epidemiology of pulmonary embolism. I'd like to help us understand how to risk stratify patients with this condition. I do want to focus some time on trying to understand who should be treated with systemic thrombolytics, especially at the point of diagnosis, and know when to refer for invasive management of pulmonary embolism. PE is a highly morbid condition that is incredibly common, with 250,000 hospitalizations per year in the United States and 100,000 related deaths. We know that this is a condition that is not uniformly experienced, and that as we get older, these conditions become more common. And while men tend to have more PEs than women, we know that younger women have a higher rate than age-matched men. Moreover, we know that there are contributing risk factors that may be transient, such as orthopedic surgery or malignancy, that place patients at increased risk of developing a venous thromboembolic disease. It's critical to understand that not all pulmonary embolisms are alike, and to have some framework from which to risk stratify the patient. The most critical patients to understand are those at a high risk, meaning those that are in cardiac arrest or cardiogenic shock, who would require prompt resuscitative efforts and potentially the need for mechanical circulatory support. Barring those patients that are in cardiogenic shock, further risk stratifying lower risk patients is helpful, as it can help understand who is more likely to decompensate in the near-term future and may benefit from invasive therapies. Finally, understanding patients that are at low risk can help relieve the hospital care burden for these patients and allow for prompt outpatient care and discharge from the emergency department without requiring an admission. So let's start by sharing the patient here. We have a 63-year-old who shows up to the hospital with near syncope. On arrival, the blood pressure is, systolic blood pressure is 50. The patient is tachycardic. And I think we would all agree that this patient is incredibly high risk. And in fact, patients in this risk category have a short-term mortality of 30%. And it's helpful to remember that sudden death is the first symptom of a quarter of all PEs that are diagnosed. So this is a very highly morbid condition. In this case, you can see from the CT images provided that the patient has complete occlusion of the right PA and extensive thrombus in the left PA system. The right ventricle is remarkably dilated with a diameter that's nearly twice that of the left ventricle. So this is what high risk is. Patients who present with a blood pressure of less than 90 for more than 15 minutes with requirements of pressors, and a definition of a PE either with CT or VQ scan, or a clinical history and collaborative findings such as acute RV dysfunction and lower extremity Dopplers that show evidence of embolic disease, thrombotic disease. If this patient is found to be high risk, it is critical to quickly consider and treat with systemic thrombolytics. And not only to be prepared to treat with thrombolytics, but to have a plan for escalation of care, particularly for the use of mechanical support, such as ECMO. One of the pitfalls of using systemic thrombolytics is that there are major contraindications to this therapy that limit the patient population that's able to seek care with systemic thrombolytics, which are relatively easy to give but can have catastrophic complications. I won't go through each of these for the audience, who I'm sure know this as well as I do, but it is important to recognize that there are absolute contraindications to the use of systemic thrombolytic therapies. How to use the systemic lytics for those of us that, including myself, that grew up in times of not using these agents for MI. Just a reminder here. So for the use in PE, alteplase 100 milligrams over 2 hours with an initial bolus and an 80 milligram infusion. Alternatively, tenecteplase can be used on a weight-based bolus, rapid bolus as well. This is some area of controversy is what to do with anticoagulation while using full-dose systemic lytics. And in general, the recommendation is to use bolus and infusion per a standard protocol. However, this practice does vary, and some centers will use a flat dose of systemic heparin until the lytic infusion is complete. It is important to avoid low molecular weight heparin, warfarin, or direct oral anticoagulations in the first 24 to 48 hours after lytics, as the bleeding complications may present either acutely or in the near acute term, and you would want to avoid concomitant use of long-acting irreversible anticoagulants. So what's the benefit for this therapy, right? So what do we actually get for this? Well, it looks like there actually is a mortality benefit when you combine all prospective clinical trials in this space, and with a reduction, with an odds ratio of 0.53 in a pooled analysis of over 2,000 patients. But it's critical to understand that this database is not clean. And in fact, of these 2,000 patients that are randomized in this meta-analysis, only 31 fall into the true high-risk category. And the absolute mortality for the anticoagulant group was nearly 4%, and with lytic therapy was 2%. So this is very different than the 30% mortality that we discussed for the high-risk population alone. And the takeaway from this, for me, is that clearly there is some signal of benefit for the use of systemic anticoagulation, but perhaps there is a high-risk population that truly derives a higher benefit, and there may be a lower-risk population that does not necessarily benefit from this intervention. As I mentioned, complications can be serious, and in fact, major bleeding occurs in 10% of patients exposed to systemic thrombolytic therapy, with a number needed to harm of 18. And as the patient age increases, and in fact, in patients greater than age 65, the number needed to harm is as low as nearly 10. And intracranial hemorrhage, really the dreaded complication from this, in which an event can be fatal in 1 in 3 patients, occurs in up to 2% of patients that receive systemic thrombolytics. So how did this patient do? So this patient was persistently hypotensive despite being on norepinephrine and receiving fluid resuscitation. The PE diagnosis was confirmed. The patient received alteplase and was off pressor support within an hour and on room air the next morning, really showing the dramatic impact of what is bedside therapy in this critical illness. So what can you do when you are unable to offer lytics? Remember, I shared with you that there are major absolute contraindications to the use of thrombolytics. And here's a case from our hospital, a 37-year-old woman with protein CNS deficiency who was post-op day 4 from a small bowel transplant, who became acutely short of breath, requiring a non-rebreather, was tachycardic, and had evidence of right ventricular injury with elevated troponin and BNP. And you can see here on the CT scan that the patient has a saddle embolus that is obstructing both the right and the left PA, and that the RV is significantly dilated. Given that this patient is post-op day 4 from major surgery, she is not a candidate for systemic thrombolytic therapy. This is the fellow's bedside echocardiogram that they texted to us on call. And you can see here that the RV is akinetic. There's evidence of a McConnell sign where the apex is being dragged by the LV at the insertion site. And the RV is severely dilated. So thankfully, there are multiple mechanical options for thrombectomy, percutaneous thrombectomy, that do not require the use of thrombolytic therapy and that have been shown to be beneficial in this patient population. And the 3 products that are on the market in the United States that are frequently used include the Inari FlowTriever system, the Angiodynamic AlphaVac system, and the Penumbra system from Indigo. All of these share some similarities, and they suck out the thrombus. The AlphaVac and the Inari system are large bore, up to 24 French. The Penumbra system is lower profile at 12 French, however, it uses a mechanical pneumatic suction system, whereas the other devices use manual thrombectomy. So here's our patient study. We took an Inari 24 French catheter up, and you can see here from the initial angiogram that the right thrombus is at the tip of the catheter. And you can see here from the left angiogram that there's extensive thrombus in the left-sided system, and that following thrombectomy, the perfusion to the left lung is markedly improved. And here's what we sucked out of this young woman: very large thrombus burden with an immediate improvement in her heart rate from 120 to 90. Her oxygen saturation improved, and she was discharged 3 days later on room air and on oral anticoagulant therapy. So this really highlights to me that there is a opportunity for the use of non-systemic lytic therapies in patients with high-risk PEs. So the 3 options that are available currently are suction thrombectomy with the devices that I shared with you earlier, and the clinical trial data that's available for this shows that there is an improvement in RV to LV ratio. Alternatively, surgical embolectomy is another paradigm of treatment that has been shown to be effective and has the advantage of being able to place the patient on cardiopulmonary bypass percutaneously before inducing anesthesia, which can be critically important in patients who have acute compromise of the right ventricle. One of the advantages of this therapy is that the patient circulation is in complete control. However, some of the disadvantages is that only very proximal disease in the main and the right and left pulmonary artery can be accessed surgically, and it requires the presence of a surgical and anesthesia team that is available 24/7 and able to respond to these kinds of cases. Another percutaneous therapy that is possible in these patients is the use of catheter-directed lytics. Catheter-directed lytics allow for the use of a much lower dose of thrombolytic agent that is directed into the thrombus bed directly via catheters placed from either the internal jugular or the femoral veins, and has a much lower bleeding risk compared to systemic lytics, and has a growing evidence base showing, again, improved RV and LV ratio, improved pulmonary artery pressures, and potentially an improvement in outcome that should be the subject of soon-to-be published clinical trial data. One of the disadvantages of catheter-directed lytic therapy, though, is that the patient requires a prolonged admission in the intensive care unit where they require close monitoring for hemorrhagic complications of thrombolytic therapy. While there have been all of these advancements in the treatment of PE, such as catheter-directed lytics, suction thrombectomy, and surgical embolectomy, to date there have been no high-quality randomized clinical trials to show that these interventions demonstrate a mortality benefit over plain anticoagulation. And again, this will be the subject of clinical trials that are currently enrolling and should be quite impactful in how we change our clinical practice. I'll share a few more clinical cases here. So this is a patient not quite in shock, but not looking very good, who presented with acute shortness of breath and syncope and was transferred from a referring community hospital. The patient was tachycardic, was hypoxic and hypotensive, had positive biomarkers and elevated RV. The PA pressure on arrival was elevated, suggesting that there was some element of chronic pulmonary hypertension in addition to the patient's acute injury. And you can see here from the CT scanner that the patient's right PA is occluded and that there's thrombus extending into the left PA as well. Again, we took the Inari system here, a 24 French system, aspirated large clot burden from the patient's pulmonary artery with a remarkable improvement in his hemodynamics immediately on the table and with normalization of his right ventricular function prior to discharge on day 2 on room air. So there remain unanswered questions. Do we know what the comparative efficacy is of suction thrombectomy versus catheter-directed lytics? And the answer is no. Do we have hard outcome benefits for these patients? Do we know that these invasive therapies have palpable advantages over systemic anticoagulation? And to date, the answer is no. And then, with the presence of these therapies that do carry substantial costs, what are the societal and the individual patient benefits, and what are our abilities to deploy these therapies quickly and uniformly across different patient populations? And then finally, I think an area that's going to be critically important as we better understand shock in these patient populations is what is the use of mechanical circulatory support, especially ECMO and dedicated right ventricular pump support devices. So in conclusion, I hope that I've shared with you that pulmonary embolism is a common condition, that risk stratification of these conditions can help identify patients who might benefit from advanced invasive care. I think it's critical that really for all acute care physicians, whether you're a cardiologist or not, to recognize that a high-risk PE patient who is in shock should be treated with systemic lytics at the point of presentation, and that this therapy does have a demonstrated benefit. I think that I've shared with you that contemporary PE therapy allows for non-lytic based options that can promptly reverse hemodynamic impact of PE, and that in patients with persistent shock, that escalating their care to centers that are capable of performing a mechanical circulatory support may allow for cardiopulmonary recovery and survival of the patient. I thank you for your kind attention, and thank you for this invitation to participate on this panel.
Right. So some of the challenging interventions that we've faced in the recent couple of years that we've been working, that I'll be sharing with you. Now, acute coronary syndrome is a vast clinical spectrum. It can start off with patients with unstable angina, wherein the pain may not be that significant. ECG may be normal, the troponin may be negative, to a non-ST elevation MI, wherein you have raised troponins, more significant ECG changes, more significant pain, to a full-blown ST elevation MI, where you have, of course, ST elevation on the ECG. The patient can be crashing, the patient can be collapsing in cardiogenic shock or pulmonary edema. So the full-blown spectrum, and that we need to be aware of when we are treating these patients. Now, STEMI, of course, the intervention strategies are very, very clear. The choice of treatment is primary PCI. Whenever you have a patient with acute ST elevation MI, so emergent coronary angiography should be done, and PCI of the infarct-related artery should be done. And this is accepted and well known all over. Then there are certain other terms like rescue PCI. What is rescue PCI? When you do and you lyse the patient with thrombolytic therapies and you don't see the required response, you see the patient has persistent chest pain or persistent ECG changes. In other words, a failed lytic therapy, you take these patients for rescue PCI. Then there's something called as routine PCI after thrombolysis. This is a recent concept that has come in the last 6 or 7 years, wherein after thrombolysis, the patient is taken up for a routine angiography between 2 to 24 hours after the thrombolysis. And then we see if the artery is patent, how the flow is, and if required, we do an intervention. And pharmacoinvasive therapy is fibrinolysis combined with rescue PCI or routine early PCI in case of successful lysis. Now, when it comes to non-ST elevation ACS, somehow the guidelines are not taken that seriously by the emergency team members or sometimes even by cardiologists. Remember, these are the ESC 2020 guidelines, and they focus on the timing of invasive strategy in non-ST elevation ACS. So all patients who have at least one high-risk feature like hemodynamic instability or cardiogenic shock, recurrent or refractory chest pain despite medical treatment, life-threatening arrhythmias, mechanical complications of MI, heart failure related to non-ST ACS, and presence of ST segment depression more than 1 millimeter in more than 6 leads, or along with ST elevation in AVR or V1, suggestive of a left main or a triple vessel disease. These are indications where the invasive strategy should begin within 2 hours. And what happens to the rest of the patients? And patients who have high-risk criteria like diagnosis of NSTEMI, meaning troponin is elevated along with the clinical context of an acute MI, these patients should undergo early invasive strategy within 24 hours. Other features could be dynamic or new STT changes suggesting ongoing ischemia. Any ST elevation, even if it's for a few minutes, that should be considered serious. And if the patient has a high risk score. Other patients deemed low risk can be selected for ischemia testing, or nowadays we're also considering CT coronary angiography in these low risk patients with ACS. What are the challenges we face in intervention in patients with ACS? So first and foremost is time. The time is the essence of treatment. The more time you lose, the more muscle you lose, and the worsened chance of mortality. So the Cathlab team has to be ready 24/7, which we are most of the times. And most of the times, our ER physicians will agree, most MIs present at odd hours, 3 a.m., 4 a.m. And then, so the team has to be really on time and pick up the patient. And ongoing ischemia and the large myocardium at risk. So if you don't treat these patients, you will lose a large amount of myocardium, and the patients can have heart failure and other complications. There is an enhanced thrombotic risk because acute coronary syndrome is a prothrombotic state wherein you will see a lot of coagulation happening everywhere. The patients can be hemodynamically unstable with tachycardia, hypotension, and all that. There can be electrical instability in the form of ventricular arrhythmias, heart blocks in presence of inferior LMIs. Patients may have bleeding tendencies because they've been loaded with heparin and with ticagrelor or with aspirin. You may not have lab reports ready. You don't know what is the creatinine of the patient. You don't know what the hemoglobin is of the patient when you're taking up an acute STEMI patient. The late presentation is a frequent challenge, and somehow still, I was telling Dr. Adel, our patients still come late, 10 hours, 12 hours after the acute MI. And so this poses a challenge in the intervention. So there is more organized thrombus when you start operating on these patients, more chances of slow flow, no flow that we see when we see these patients with the late presentation MI. Then there can be multivessel disease. There can be left main disease. There can be a challenge coronary anatomy like a bifurcation. Then there are challenges that are limited to elderly population and women as well. So instead of going into the theory, I would be focusing more on case-based approach on how we've dealt with these patients. So our first case, a 45-year-old Indian gentleman, non-hypertensive smoker, had acute chest pain since afternoon, comes to our hospital at around 1 a.m. So almost 12 hours after the onset of chest pain, he comes to us. Still has ongoing chest pain. The blood pressure is on the borderline, 96/60. The ECG shows acute inferior STEMI with Q waves. Thankfully, the rhythm is still sinus. There is regional wall motion abnormality, EF 50%, and mild mitral regurgitation. So at 1 a.m., we take up this patient for coronary angiography. So this is the angiography of this patient. Yeah, so this is the left system. You can see this is the LAD artery, and you can see a nice demonstration of myocardial bridge in the LAD artery. The mid part of the LAD artery gets squeezed during the systole. It is called myocardial bridge. And also you can see faint collaterals going to the right side. So these are the collaterals going to the right side. And this indicates that, of course, the right coronary artery has a significant occlusion. Also, the right artery seems to be a dominant artery and a large one. And then this is the injection of the right coronary artery. So you see completely occluded proximal right coronary artery. And so now, what are the challenges that we can anticipate in this patient? Hemodynamic instability. Patient already has blood pressure on the lower side. He's been bolused with fluids, and ongoing fluids are there. The team is ready with inotropes. The team is ready with the atropine. Atropine is loaded, labeled, and kept. And a temporary pacing wire is ready in case we require it. Earlier, we used to, a lot of cardiologists used to put prophylactic temporary pacing wire in patients with inferior MI, but the practice is slowly fading away. We have it in the cath lab ready in case it is required. The other challenge we anticipate in this patient is a huge thrombotic load, because this patient has come to us 12 hours late with a large MI, with a large myocardium at risk. And so we've already preloaded this patient with aspirin and ticagrelor. His patient is paralyzed with 10,000 units of heparin. GP2B3 inhibitor tirofiban is ready and loaded in the cath lab. And we have aspiration catheters ready in case we find a large thrombus. And patients can get electrically unstable. So defib is attached. The anesthesiologist is available in cath lab at 1 a.m. And so we have anticipated some of these challenges, and we are ready to overcome these. So we start the primary PCI. The first injection after putting a wire shows a large thrombotic burden, as was expected. So this filling defect that you see here is the thrombus. So the initial strategy was to do a balloon dilatation and see if this thrombus can get plastered to the wall and give way. And after the balloon dilatation, you can see this is the huge chunk of thrombus that is there in the mid RCA. There is about a 90% lesion just proximal to this thrombus burden, and we expect now this is what needs to be tackled. This is the other view where we can see the thrombus clearly, large filling defect, and some thrombus also seen in the PDA branch of the right coronary artery. So considering this thrombus, we start doing a thrombus aspiration. We put in an export catheter right into up to the distal RCA and pull down the thrombus. We could manage to pull out two large chunks of thrombus. And after that, we see a bit of good flow is there, but still the thrombus is there. And then after 2 rounds of thrombosuction, I decided to further balloon it. And this is the ballooning in the proximal RCA. And then after that, we see the flow is there, but there is a small dissection in the mid coronary artery, mid right coronary artery. So now decided to put in the stents. So the 2 stents are put, 4 millimeter size regulating stents. And these are the stents that are put. Now, is this the end of the story? No. So we see after putting the stents that there is some slow flow. The flow is not as brisk in the distal part of the right coronary artery. And in this view, you can see the PDA branch appears completely occluded with slow flow. And so we need to tackle this now. So initially started with dilating this with balloons. 1 balloon and another balloon, and then still the flow was not that good. So we decided to do another round of thrombosuction. So this is the flow after the balloons, and another round of thrombosuction is done. We put the thrombosuction catheter through the stents right into the distal right coronary artery into the PDA and started sucking out the thrombus from there. Managed to pull out large chunks of thrombus, and after this, the patient was also given intracoronary tirofiban. Further ballooning was done, intracoronary adrenaline was given, and fluid boluses were given. ACT was maintained at around 300. And finally, we could manage to get a good flow in the distal right coronary artery. So now you can see the distal RC and the PDA are filling. The patient was discharged after 3 days, follow-up for 2 years now, is asymptomatic on optimal medical management, stopped smoking, EF has improved to 65%, had a recent treadmill test which is negative. So this is how we anticipate procedures and complications during procedures. The second case is an interesting case. It's an anomalous left coronary artery presenting with an acute MI. I had the opportunity of presenting this case at the Gulf PCR meeting in Dubai in December. So this was a 50-year-old Pakistani gentleman, known case of hypertension and hyperlipidemia. So having chest pain for the last 3 days, was admitted to Salmania Medical Complex, treated as non-ST elevation MI and discharged. He came directly after discharge to my clinic. While waiting outside the clinic, he was having recurrent chest pain. So took him to the ER, did the ECG. ECG showed sinus rhythm with T inversions in L1 AVL and small ST depression in L3 AVF. Echo showed hypokinesia of apicollateral segments. Ejection fraction was still preserved. Troponin was very high. And so we decided to do the angiography of this patient. So angiography done from the right radial root. And we can see this is the right coronary artery injection. Some mild disease in the mid part, some mild disease in the PDA, but this is not the culprit. So we're starting to search for the culprit. Now we're trying to search for the left coronary artery. We're not able to engage the left coronary artery. We can see a bit of calcium and a track of the left coronary artery, but the left coronary artery is not seen in the left cusp. So tried a different catheter, a large 4.5 JL to see if it will engage, but it wouldn't. And then another catheter took a guiding injection and then took a non-selective injection there. Here, I mean, if you can appreciate, you can see a faint filling of the left coronary artery here. It's coming from the right coronary cusp with a very, very faint filling that could see. So now it's very important when you see, we don't see the coronary artery in its normal position to review all the injections we have taken to see if we can see a faint filling from the opposite coronary cusp or sometimes from the non-coronary cusp. So then the challenge was to engage it, and it was engaged with a multi-purpose diagnostic catheter. Now we can see the left coronary injection is being filled. And then as we go on here, you can see this is the left circumflex artery, which is totally occluded, which is the culprit artery. Also, we see a tight stenosis in the LAD artery. Now we decided to do both of these arteries. Now the next challenge, this is a diagnostic catheter, and the next challenge was to engage it with guiding catheters. So I tried to cannulate with the same multipurpose. Instead of diagnostic, took a guiding catheter. As you can see here, it was engaged, but I did not achieve good cannulation. Tried with various catheters like Judkins right, Judkins left, Amplats, but they were not successful. Then what I tried was I engaged again with the diagnostic catheter. Through the diagnostic catheter, I put in a wire very well distally into the LAD. And over this wire, I tried to cannulate the guiding catheter, Judkins again. So I was able to engage the Judkins catheter, but as you can see, the alignment is not proper. I was scared I might dissect the ostium of this anomalous left main. And by this time, because we have exchanged too many catheters, patient already has radial artery spasm, and any more interventions were being difficult. And I decided, let's go femoral for this patient. Let's see if a femoral approach will engage this patient. And luckily enough, with the 6 French Judkins right 4 catheter, I was able to engage the artery. And then, this is the wiring of the left circumflex artery, then ballooned it, put in a stent, and this is the result of the left circumflex artery. Then did the PCI to the LAD, 2 stents in the proximal and mid coronary artery. And this is the final result. You can see very well filling a LAD and an LCX. And you can see this LAD also very nicely, beautifully filling. So this was a very satisfying result. But then we also needed to find out what is the course of these coronary arteries. The anomalous left coronary artery, when it arises from the right, seen in about less than 1% of the population. The course can be interarterial, where it moves between the aorta and the PA, wherein it is considered to be malignant. The artery gets squeezed between these 2 arteries at high pressure, and these patients are candidates for surgery. The course can be septal or subpulmonic or retroaortic or anterior to the pulmonary artery. Retro-aortic course is the less common anomaly and usually considered benign. So the best modality to look at this is a CT coronary angiography. So we did a CT coronary angiography for this patient. So here you can see this is the right coronary artery. The left coronary artery arises just below the right coronary artery, but a separate origin. It courses between the aorta and the left atrium, away from the pulmonary artery, and then divides into the LAD and LCX. Our technician was able to make this beautiful video where you can see this is the right coronary artery, this is the pulmonary artery. So this is the aorta. Let me play it again. Yeah, so this is the anomalous coronary artery, goes between the aorta and the left atrium into this chamber. The left atrium is a low pressure chamber, so it does not compress the coronary artery. And then these are the divisions into the LAD and LCX. So a beautiful video construction is done of this. This patient has followed up us for almost a year now. We did a treadmill test for him recently, which was negative, and is doing well. Now, the third challenging case is a 79-year-old Palestinian lady, has diabetes, hypertension, chest pain for one day. ECG shows a left bundle branch block. Tropa is elevated, diagnosed as non-ST elevation MI. Echocardiography showed a moderate aortic stenosis, EF of 45%. And so the challenges anticipated is she's quite old. So you might expect calcium, there's calcium in the aorta. So you might expect calcium in the coronary arteries as well. And that is exactly what we found. So this is the right coronary artery. The proximal and mid parts are clear, but the distally there is a very tight lesion, about 90%. And it's a big RC. And then you see the left system, LCX looks all right. There's a very tight stenosis in the LAD artery. There's a diagonal, which is about 1.52 millimeter, which is close, but then there's diffuse disease beyond it. So we decided to tackle the LAD and the RCA. This is the LAD in another view. You can see a very tight stenosis here and then here. So it is very calcified. Now the options are for us to go for rotablation or do IVL. For that, we'll have to postpone the procedure and call her back when the IVL is ready. But this is a non-ST elevation MI, so we cannot afford to do that. So we decided to go ahead and do the plasty with a cutting balloon. So we wired this patient, a little bit of difficult wiring, but then the wire went in. Then we took a 1.5 millimeter balloon. It would go up to this part, but not beyond this. So decided to take a smaller balloon. The smallest we had was 1.25. Even this would not navigate the course. You can see the catheter is being pulled back when we're trying to push the balloon. So anyway, we dilated this at that point, it's still not managed to pass. Then I used a technique that we've learned during the our cardiology training days, put another wire, and in the presence of another wire, ballooned this coronary artery here. So the wire acts like a cutting balloon. So tried this as well. And this one also, you see a little bit of better flow, brisker flow, but the lesion has not yielded. Now the bigger balloons are not passing, so we decided to take a guide liner catheter. This is the guide liner catheter. It is a smaller catheter that sits inside the bigger catheter, and we can literally push this catheter into the coronary artery. So we pushed gently this guide liner catheter across into the mid LAD. And with that support, we were able to push the balloon down. And then we dilated the balloon. And then more balloons. And then now you can see the flow is a little better. The lesion seems to have given way. And then we managed to put in 2 stents in the LAD artery. And these stents are, of course, post-dilated for optimization. And then this is the result of the LAD artery, as you can see. So beautiful results in the LAD artery. We did the RCA also. I'm not showing that for the sake of time. And this was the RCA result, the huge RCA. Patient had some hypotension, bradycardia during the procedure, treated with atropine, fluids, intracoronary tirofiban, and stabilized in the cath lab. Monitored in the ICU for 2 days, discharged on the 3rd day with an ejection fraction of 55%. She's followed up a couple of times after that, and she's doing well. The 4th case of the day is an acute evolving MI. So 37-year-old Bahraini gentleman, strong family history of coronary artery disease. His elder brother had a cabbage when he was around 40 years old. Despite that, this patient smokes heavily, has hyperlipidemia as well. He presented to us with severe crushing chest pain for 1 hour. This was the ECG of that patient, sinus rhythm. You can see a slight ST elevation AVL, also hint of ST elevation AVR. Then you see ST depression in L1, L2, L3 AVF, V5, V6. We see these ST depressions. Troponin is elevated. And so we decided to take him severe crushing chest pains. So we decided to take him for coronary angiography. So as you can see, there's a lesion in LCX and there's a lesion in LAD. So very tight lesion across the diagonal branch. Diagonal is also a big size branch, around 2.53 millimeter artery. And the ostium of the diagonal also has some disease. So this is what we call as a typical bifurcation lesion, Medina 111. We need to tackle this. So now started the procedure. Put in 2 wires, one into the LAD, one into the diagonal, balloon the diagonal, balloon the main artery. And then we decided to go with the mini crush technique. So mini crush technique is where we take in 2 stents simultaneously. We put a stent in the side branch, just a couple of struts into the main artery, and then we crush the side branch stent with a bigger stent in the main artery. So this is how it works. So you have a stent in the main artery, you have a stent in the side branch. This side branch has only a couple of struts protruding into the main artery, and this gets crushed when you deploy the main artery stent. And then after this, we recross through the stent struts. We remove the wire from the side branch. We recross through the stents, through the crushed stent struts into the side branch. We're able to do that successfully. Then dilated serially with a 1.5 balloon, then a 2 millimeter balloon. And then this is a proximal optimization that we did. And after that, we did a simultaneous kissing balloon inflation. So wherein we are deploying 2 balloons simultaneously in the side branch and the main branch. And after that, we did a report, that is proximal part of the stent is dilated with a bigger balloon so that all these stent struts are opened up. And this was the final result of this patient. Really good result. Both the LAD diagonal are flowing very well, and the patient did very well for this. So this is the last case of the day. 72 years old, Indian lady, known case of diabetes, hypertension, hyperlipidemia, had acute severe chest pain since morning 9 a.m. She refused to go to the hospital. One of the cardiologists who lives nearby her home convinced her to get an ECG and a troponin. ECG did not show any STD changes, but the troponin was elevated. So the patient came to the hospital around 11 o'clock in the night with an elevated troponin and ongoing chest pain. Also had one episode of ventricular tachycardia. So we are dealing with an unstable patient with a non-ST elevation MI. This is the ECG. You can see more or less looks normal, not much STD changes. So we thought maybe this is a balanced ischemia that we are dealing with, or a left main intervention that we're dealing with. So whenever you see a patient with crushing chest pain, troponin elevation, but the ECG and echo are not able to localize where the infarct is, suspect left main or a triple vessel. So we took up this patient for angiography. As you can see, there is, as suspected, there is a lesion in the left main coronary artery. There's a large chunk of thrombus sitting there. And from there arises the left circumflex. Ostium has about 70 to 80% stenosis. The LAD also has disease. Immediately after the thrombus, we see disease here in the proximal and mid part. And so this is what it is now. So we are dealing with a 72-year-old lady who is unstable, has had VT, and has a thrombotic lesion in the left main and critical lesions in the LAD and circumflex. So explain to the family that the risks are involved. The patient may crash, the patient may arrest, and this needs to be done urgently. So this case, we started around 11 o'clock in the night. The challenge is anticipated migration of the thrombus. You try to intervene, the thrombus can go into the circumflex or distal into the LAD and produce a massive infarct. Patient can become hemodynamically unstable. Patients can have arrhythmias like VTVF. Patient can go into pulmonary edema, vascular complications. But what we did not anticipate was this is a very non-cooperative patient. She seemed fine until we did the angio, and after that she started getting very restless. So we had to call in our anesthesiologist was with us, and he had to sedate the patient. And then we were able to do the procedure. So 2 wires put into the LAD and LCX. The LAD, this mid part is ballooned. The LCX is ballooned. There's a stent deployed in the mid LAD. Then a stent is deployed in the LAD into the left main coronary artery. And now the tricky part is to wire the circumflex. So we need to wire the circumflex. So we recrossed into the circumflex through the stent struts in the left main, and then ballooned that circumflex. And then what we found was a dissection in the circumflex artery, a large dissection. Tried to fix it, did a balloon of this, and then after balloon dilatation, somewhat better looking dissection here, then decided to stent this. So now we are faced with a challenge. There's a stent in the left main, and through the stent starts, we have to put in stents into the circumflex. We tried taking a larger stent, but the stent would not go. So we took a smaller stent to cover the proximal part of the dissection. That was covered, but you can see the dissection extending down. So we took another stent, covered the distal part of the stent, and took another stent and put it between the two stents. So 3 stents deployed in the circumflex in sequence, and post the stent deployment, you can see the flow is very well maintained in the circumflex. And then did the optimization, did simultaneous kissing balloon inflation for the left main and LCX, did a proximal optimization for the left main stent. And then this was the final result. So you can see good flow in the LAD, LCX, the thrombus is nowhere to be seen. And we can see very good flow. This patient has followed up with us now for almost 6 months, and she's stable and she's doing well. So conclusions, coronary interventions in patients with ACS can be really, really challenging. It depends on the patient characteristics. What is the age of the patient? What is the mode of presentation? What is the time of presentation? Patient comes to you late, expect thrombus. Patient is old, expect calcium. And most challenges can be anticipated in advance, and the cath lab team must be prepared to handle this. Sometimes there can be unexpected problems like the one we saw with anomalous coronaries. You don't expect this 1% of the population that has this. But if it is there, then you should be ready to tackle this. You can see unexpected complications like dissection, the one that we saw. And if you see it, then you should be prepared to handle this. Of course, we have our CT surgery on backup when we're doing these extremely complex cases. Intracoronary imaging, if available, can be very helpful. Ultimately, it is a dedicated team effort from all of us, which is essential in dealing with these complicated ACS patients and thus help in improving patient outcomes. Thank you very much.
Thank you, Dr. Aziz. Kingdom of Bahrain has witnessed changes in its social and cultural pattern, which has also played a major role in the healthcare industry. To mark up with the advancement of this beautiful country, Bahrain Specialist Hospital has always outstretched its wings to contribute to the healthcare community by establishing centers of excellence. To name few, we have Bahrain Gastroenterology and Hepatology Center, BSH Apollo Heart Center, BSH Neuroscience Center, BSH Spine Care Center, BSH Breast Care Center, and BSH Diabetic Care Center. As we have heard from our previous speakers about the advancement in minimal invasive and intervention procedures with cardiac sciences, the following speaker will discuss some other areas where interventional procedures are expanding the scope of services in healthcare. He will also share updates from BSH on the scope of services being introduced in interventional radiology, as it is the first hospital in the private healthcare sector in Kingdom of Bahrain to start a unique subspecialty in the medical imaging field through the launch of its Department of Interventional Radiology, and also to share updates about BSH collaboration with Dr. Nabil Al-Shafi'i and Neurospine Center. Please welcome the Managing Director, Dr. Qasim Ardati.
Bismillah ar-Rahman ar-Rahim. Thank you very much for the introduction. Thank you all. Thanks to these special speakers that came from different parts of the world, far away from Chicago and from the States. And we are very proud to have these speakers with us today. Of course, especially our local guests, not guests as a matter of fact, but members of the family. And we are very proud that you have been able to join with us. What I wanted to say just very briefly is that, just a couple of months ago, BSH celebrated 20th anniversary. And 3 years ago, we started our cardiac service, the BSH Apollo Cardiac Center. And just recently, we started with interventional radiology. And it is with this theme that I would like to announce that we are introducing and starting in the private sector, also for the first time, the interventional neurology and interventional, of course, interventional radiology services. The association with Dr. Nabil Shafi is a fantastic thing. The team is really going to be composed of neurologists, neurosurgeons, interventional radiologists, interventional neurologists, and you will hear about it later on. But I would like to now launch these services at BSH, and I'd like to call Dr. Najah and Dr. Nabil with me to unveil these plaques and to announce the launching of these services. Dr. Mutu, can you join us, please, also? Can I call Dr. Mudathir also to join us, if you don't mind? Dr. Mahmoud is with us here. I don't see him in the front. Dr. Mahmoud. Thank you very much. Thank you.
I just want to say a word of thanks to my son, Majid Zayani, who's instrumental in the administration of our hospital. He takes a lot of the burden and headaches that we as doctors cannot handle.
Minor correction, Majid Ardati.
Thank you, everyone. And now let's go back to our speakers. I'll hand the mic to our moderator, Dr. Shaikh Bucks, to introduce the next set of speakers. Dr. Shaikh.
Thank you, sir. Our next speaker is a very dynamic and very talented interventional radiologist from Bahrain Specialist Hospital, Dr. Muttu Subramaniam. Dr. Muttu is a specialist interventional radiologist at Bahrain Specialist Hospital. He finished his Bachelor in Medicine, Bachelor in Surgery, MBBS at Stanley Medical College, Chennai, Tamil Nadu, India. And he finished his European Board of Interventional Radiology at Cardiovascular and Interventional Society of Europe, Vienna, Austria, last 2022. He is performing a wide array of interventional radiology procedures and an expert in reporting of diagnostic imaging studies such as radiographs, fluoroscopy procedures, ultrasound, CT, MRI, and PET-CT. He will be speaking on the spectrum of interventional radiology procedures. Please welcome Dr. Muttu Subramaniam.
Thank you, Dr. Bucks, for a brief introduction, and good evening to one and all present here. And I would like to take the opportunity to just give a brief insight about the variety of interventional radiological procedures which can be performed. So what is special about interventional radiology? These are novel therapeutic treatment options which are done in a minimally invasive approach and with the less complication rates with high accuracy. And most of these procedures are done under a pinhole access with under local anesthesia or mild intravenous sedation so that the patients have a faster recovery. Like this colorful spectrum, we have a colorful range of procedures under the umbrella of interventional radiology, ranging from simple biopsies to the complex stents and shunts. So let us have a brief outlook about each and every procedures. It's a quite number of procedures. The first common procedure which we perform is transjugular liver biopsy. Indications is the patients who have massive ascites, deranged coagulation parameters have been opted for transjugular liver biopsy, who are extremely obese and small shrunken liver can be opted for transjugular route rather than a percutaneous route, which has high bleeding risk, whereas transjugular route will have a less bleeding chances and high yield. Contraindications, patients who have a biliary obstructions are not the right candidates for transjugular liver biopsy, and patients who have focal liver lesions. And let us go through representative cases. This is a pictorial analogy. So this is a jugular access obtained, and the catheter is being catheterized into the SVC and to the IVC and to the hepatic veins, and the biopsy needle will be advanced and taken the course. This is the hepatic venogram performed and followed by the stiffener placement, and the biopsy needle is advanced into the liver parenchyma and the samples have been taken. Coming to the next procedure, transjugular renal biopsy. Similar to the liver biopsy, patients who have massive ascites, deranged coagulation parameters can be opted for the transjugular route rather than a percutaneous route, and patients with horseshoe kidneys can be opted for. And patients, sometimes we tend to see patients with hepatorenal syndrome, whom the sampling has to be done from both from liver and also from the kidney. So transjugular route makes a much more safer way to take sample from both rather than puncturing the kidney and liver separate. Contraindications for this procedure is thrombosis of the renal vein or the IVC. So this patient is a young female who came to us with the hepatorenal syndrome with deranged liver and the renal parameters. So we suspected the autoimmune pathology, for which the biopsy has to be taken from the liver and also from the kidney. So this is the hepatic venogram in the right hepatic vein and the stiffener placement, followed by the biopsy sampling of the liver. And further, we advance the sheath into the lower pole renal vein, and this is the angiogram showing the renal veins. And this is a stiffener inside the lower pole renal vein, and this is a biopsy needle getting advanced to the renal parenchyma for taking the shot. So we all be wondering with the fluoroscopy guidance how we outline the kidney and how we outline the liver. So that's why we have modified the techniques. We use ultrasound in conjunction with fluoroscopy so that we can see the real-time advancement of the needle so that we prevent the capsular ruptures. So we all get challenging cases, challenging referrals in our daily day-to-day practice. So we modify our routine practices. We sometimes go way out of the box to solve the puzzle. So one such thing is a combination of imaging techniques. So recently we have published the article in Polish Journal of Radiology about the combination of CT guidance and the fluoroscopic guidance for the biopsy of the superior mediastinal masses. So this is the new technique in which the vascular sheath is being placed in the internal jugular vein, and through that the percutaneous biopsy needle is advanced under real-time guidance in the CT. So this is a representative case in which there is a right paratracheal enhancing node with loss of fat plane with the SVC. So the sheath is placed just proximal to the mass, and the biopsy needle is advanced under real-time guidance, CT guidance, where we can see the biopsy needle going into the right paratracheal lymph node. So it's one of the interesting case. This patient came to us with abdominal discomfort. Contrast enhanced CT scan was done, and this showed a right adrenal mass, which is heterogeneously enhancing, and there is a lot of blood pool within the mass, and there is a tumor thrombus extending to the IVC. We were not sure what we are dealing with. These were the radiological differentials. With the biochemical panel, we ruled out pheochromo. Still, we are left with the 4 options. So now comes what to do. If we go for a percutaneous, let us go back to the same CT scan. If we do a percutaneous biopsy, there's high chance of bleeding. If we go with the transjugular route, there's a high chance that the tumor may embolize and go to the pulmonary circulation. So both are not the right options to go ahead. It is highly risky. So then we went ahead with the transfemoral route. So we cannulated the femoral vein, parked the catheter in the IVC, did an angiogram. This is the tumor thrombus in the IVC, followed by the placement of the metallic stiffener, and we advanced the biopsy needle under ultrasound guidance. So we can see the real-time placement of the needle within the adrenal mass, and to our surprise, it came as adrenal hemangioma. So it's sometimes we have to go out of the box for the challenging cases to solve the puzzle. Coming to the next domain of procedures and interventions, chemoports and lines. So as we all know, chemoports has been used for long-term chemotherapies. It is implantable ports we keep in the chest wall, and for which can be accessed percutaneously. We do under both ultrasound and fluoroscopy guidance to attain maximum accuracy and less complication rates. Preferable venous access sites first goes for right jugular, then subclavian, then goes for the left jugular and subclavian. When the patients are completely utilized with their upper body veins. Then at the last start, we go for the femoral approach. So this is the representative case where there is a pouch created in the subcutaneous plane of the deltopectoral groove. And this is the metal tunneler. We tunnel from the pouch to the needle entry site in the jugular vein. And this is after closure. We puncture the port diaphragm with the Huber needle to check the patency of the port. So this is how the port looks after the placement. And we always keep under fluoroscopy guidance so that we keep the tip of the catheters at the level of the cavoatrial junction. So you can see that there are two different shape of ports here. This is an inverted V shape, whereas this is an L shape. So previously, when we started to put chemo ports, we were putting V shape, but the chance of kinkage thrombosis is more. So we then to modify our technique for L shape. Coming to the PICC lines, these are peripherally inserted central lines, which can be used for long-term intravenous therapy for the patients who require parenteral nutritions or serial blood transfusions or who have to go for serial blood investigations. We do under both ultrasound and fluoroscopic guidance. So we access the basilic vein, or the first choice is basilic, then comes the brachial and then the cephalic. So under ultrasound, we puncture the basilic vein in the mid or distal arm, and the PICC line is being placed with the tip at the cavoatrial junction. This is how the PICC line looks in the patient's arm. It is very cozy, comfortable for the patients. Patients can go home, they can do a daily day-to-day routine, but still we have a good central access so that patient doesn't need to be punctured every time when the patient visits the hospital. Next domain of procedures is percutaneous drainages. First, we will talk about percutaneous transhepatic biliary drainage, which is PTBD. Whenever we get a patient with biliary obstruction, the first sort is to go for endoscopic intervention. If the endoscopic intervention is negative, then we opt for percutaneous therapies. So these are the indications and contraindications. Indications, we manage malignant strictures, benign strictures. Sometimes I have a percutaneous access to give an endoluminal brachytherapy for cholangiocarcinomas, or we need an endoluminal sampling. Contraindications, patient with massive ascites and deranged coagulation parameters, we tend to either drain the ascites completely or correct the coagulation profile and then go ahead with the procedure. So the commonest pathology which we treat with the PTBD is a hilar cholangiocarcinoma. This is, we all know about this classification, Bislett-Corlett classification for cholangio-CA. So this type 1, 2, 3, and 4, mostly we get referrals for type 4 tumors. The rest of the tumors are usually have a success rates with the endoscopy. Let me show a couple of representative cases. This patient came to us with a cholangitis with high TC counts with a high bilirubin, and the MRCP showed bilateral obstruction on right and left system. This is a percutaneous cholangiogram showing the dilated right hepatic duct and the left hepatic duct. Here we can see the complete cutoff. This looks more of like a type 4 block. We can see dilated bilateral system with a block here. So this is a type 4 malignant block for which the sampling has been done, which came as positive for malignancy, and the stenting has been done on both sides. This is the next case. It's a young gentleman who has underwent a cholecystectomy a day before, and he presented to us next day with abdominal pain. We did an MRCP for this patient. Here we can see a prominent CBD, and on the right side, we can see a drain tube just in the inferior aspect of the liver with a fluid signal intensity next to the drain tube. So we were suspecting something is leaking there, and the patient's drain also showed yellowish colored discharge, maybe a bilioma. So then we went again with the percutaneous cholangiogram, and this is opacification of the biliary system. Here, this is a CBD, and you can see the drain tube also is being filling up with contrast. So this is a cystic duct leak post-surgery. So what we did, this is the oblique run. We can see nicely the contrast flowing through the bile duct. Through the drain tube, and the bile is coming through the drain tube. So then what we did is we did a diversion PTBD. So we did a percutaneous transhepatic biliary drain with the external and internal drain open for 2 weeks. So the bile get diverted and the stump got healed. So after 2 weeks, this is a cholangiogram. You can see a nice opacification of the biliary system into the duodenum, and there is no filling up of contrast in the drain tube. Coming to the next set of procedure, percutaneous nephrostomy and antegrade degestenting. Indications, we treat both benign and malignant diseases, and we treat for urinary leaks. And if retrograde aortic stenting is negative, then we can opt for the percutaneous approach. Deranged coagulation profile, severe hyperkalemia and sepsis are the contraindications, but we tend to correct the hyperkalemia and sepsis and then take the patient for PCN. This is one of the interesting case, a young gentleman with a Down syndrome who, with a neurogenic bladder, he went for a cystectomy, and followed which urethral diversion was done for him. And there was he was fine for quite some time. Then he presented with repeated pyelonephritis with high creatinine. We did an imaging, and in the contrast enhanced CT scan, we saw there is an anastomotic leak on both sides. Anastomotic stricture on both sides with bilateral hydrohydronephrosis. So what we did, we accessed the both kidneys, and this is the right kidney which has been accessed percutaneously. Sorry, I'm just trying to play the video. Yeah. So this is a contrast run through the catheter in the distal ureter, just next to the anastomotic site. Here we can see there is a narrowing at the level of the anastomotic site with the junction with the ileum. So both side has been both side kidney has been accessed percutaneously, and the bilateral antegrade DJ stenting has been done, and with a covering nephrostomy. And the covering nephrostomy was kept for 48 hours, and the nephrostomy tubes has been removed. And this patient is doing well, and his pyelonephritis settled down, creatinine declined. He is doing well now, and he is due for the stent exchange. Next, coming to the next domain of procedures, wide range of embolization. Let us have a look at what is embolization. As we all know, it is nothing but stopping the blood supply to the particular organ or tissue. And what is beautiful about this procedure is it can stop a life-threatening hemorrhage in a minimal invasive approach. Most of the times we use only local anesthesia, and patients recover fast. And what are the type of embolic agents? We have permanent and temporary agents. Temporary agents are gel foam and collagen. Permanent agents are particulate matters like PVA particles, polyvinyl alcohol particles, coils, plugs, detachable balloons, and liquid embolics like glue and onyx. So let us have a look how this embolics looks like. So this is the coils with the fibers, and this is a PVA particles of various sizes. And this is a glue, which is N-butyl cyanoacrylate. There are a variety of liquid embolics has been evolved over years. Now we have onyx squid, and this is a gel foam. So this is temporary, whereas these are permanent. So coming to, let us have a look what all arteries can be embolized and how it is useful. So one such thing is a hemoptysis. So if a patient presents to us with recurrent hemoptysis, or if the bleed is more than 100 ml over a period of 24 hours, then these are the right candidates for bronchial artery embolization. Contraindications: before embolizing a bronchial artery, we always do an angiogram to check is there any anomalous supply from the bronchial artery to the vital organs like heart, spine, or to the brain. If there is anomalous supply, we don't do an embolization. It becomes more risky. So this is a clinical algorithm how to treat, how we approach for a life-threatening hemoptysis and non-life-threatening hemoptysis. Life-threatening hemoptysis of parenchymal origin, bronchial artery embolization is the first option. If it's traumatic or iatrogenic injury, then go for surgical. If non-life-threatening, always try for conservative. If it's not happening, then go for bronchial. If it is endobronchial origin, go for bronchoscopy. If it's not happening, then go for embolization. So let us have a look at representative cases. This was one of a challenging case which I have done before. He is a middle-aged gentleman who came with a tuberculous cavity in the left lung upper lobe. He came with a recurrent hemoptysis. He bled around 200 ml over a period of 6 hours. So CT iodogram has been done. We can see a cavity over here with dilated tortuous vessels in the vicinity of the cavity. Took him for angiogram. There's a bronchial artery on the left side, which was supplying to the left lung upper lobe, which with an anomalous blush in the left lung upper lobe. Embolized it. Whenever we see, we think that is an artery which is causing the problem, but we will forget about the rest of the arteries which may also be supplying. So we always look for other supply. So we went into the left subclavian and did an angiogram. There was a supply from the costocervical trunk and also from the internal mammary artery. So went into the costocervical trunk and embolized it. We tried to cannulate the internal mammary from the femoral root, but it was not happening due to the acute angles. So took the distal radial axis on the left side and went into the subclavian and did an angiogram and went in specifically into the internal mammary artery. This is a blood, we can see the dilated channels supplying the left lung upper lobe. So before injecting a polyvinyl alcohol particle inside the internal mammary artery, we should be very careful because these particles may go into the collateral circulation into the heart or into the diaphragm. So we coil the internal mammary artery so that there's a proximal coiling so that the distal supply will be preserved with the collateral from the heart or from the diaphragm. Then we embolize the branch from the internal mammary artery. So this is a post-embolization image. Then this patient improved drastically. Within 24 to 48 hours, he was discharged. Then what all arteries can be embolized? Coming to the GI bleach, this is a pancreatitis patient with a pseudoaneurysm arising from the pancreaticoduodenal branch of superior mesenteric artery. And this artery has been accessed with a superselective approach and been embolized with a coil. We always check for any other arteries in the vicinity, whether it is supplying or not. So then coming to the renal bleeds, this patient was undergone a percutaneous nephrolithotomy, post which he had a hematuria. There was a pseudoaneurysm in the right lower pole artery, which was specifically accessed and embolized. Then coming to which organ can be embolized, next coming to the uterus. So primary PPH, we searched for bilateral uterine arteries. Bilateral uterine arteries were normal. There was no bleed at all. Then we started searching for probing for other arteries. This was a cervicovaginal branch from the left internal iliac artery, which was actively oozing. So which was coiled and the patient improved drastically. So prevention is always better than cure. So we saw about how the embolization can help us with which is bleeding. We can always prevent the bleeding by doing a preoperative embolization. If we have a highly vascular tumor, we suspect on-table huge blood loss, or it's going to be a bloody field for the surgeon, it's always better to do a preoperative embolization. So this is a case of angiomyolipoma. Which we can see a multiple arterial collaterals into the tumor and intratumoral aneurysms, which was embolized. And this is a post-surgical resection image. We can see the thrombosed vessels in the superficial aspect of the tumor. Then we have looked at what can be done for preventing the bleeding with embolization. Let us have a look at what novel treatments can be done with embolization for the commonly treated disorders. One such thing is a uterine fibroid. Indications is symptomatic fibroids with either bulk-related symptoms, bleeding can be treated with uterine fibroids. There are different literature cutoffs of size of fibroids can be treated and cannot be treated. We always have a balance of the patient, whether they're going to go on for uterine infarction or not, regarding in concern with the number of fibroids and the size of fibroids. Contraindications, patients who are pregnant and who have suspected uterine or ovarian malignancy and pelvic infections, they are not the right candidates for uterine fibroid embolization because post-embolization chance of infarction and sepsis is more. So let us have a representative look at the representative cases. So this patient came to us with a large symptomatic fibroid. She had AR and MR, so she was a high-risk candidate for surgery. So she opted for uterine artery embolization. So this is a right uterine artery run showing multiple dilated tortuous spiral arteries supplying the uterine fibroid. And this is the post-embolization image. We can see the contrast getting pulled up in the artery which is supplying to the fibroid, and there is no opacification of the fibroid at all. This is the preoperative image of the same patient, the huge fibroid. And this is a post-operative image of the same patient where the fibroid has been devascularized and there is a significant amount of reduction in the size of the fibroid. This was a 3-month follow-up. Usually we evaluate the patients in MRI pre-operatively and post-operatively. Post-op, we image the patient at 3 months, 6 months, and 12 months to see the reduction in size and also for any recurrence of fibroids. So not only for fibroids, we use embolization for treating other pathologies. This patient had a chronic menorrhagia for almost 2 years, and she actually had a history of DNC. So this is the angiogram image, which we did for the right uterine artery. We can see the dilated uterine artery, and there's early filling of the internal iliac vein. So this was a uterine AVM, which was embolized with the glue. So this is a glue cast going into the artery and then going with capillaries. So we always have a debate for uterine arteries, whether the fertility and pregnancy is going to be affected or not with embolization. It's always been a debate, and there are a lot of literature articles on either side. So some support myomectomy and some support embolization. So what we did is we did a retrospective research on what cases we have done. So we have done embolization for fibroids, AVMs, PPH. So we pulled up the data and did a retrospective study for the reproductive age group female, and we found there were 86% positivity for fertility and future pregnancy. And we published this scientific data in the Interventional Radiological meeting in New York. So next, coming to the next procedure, varicocele embolization. So who are all the right candidates? Symptomatic varicoceles, patients who are have a treatable cause of fertility, infertility, who can be made fertile with the varicocele embolization, and who have a failed surgical ligation. Contraindications, patients who have renal impairment, and the pediatric population, we don't advise the embolization. Rather than we can go for a surgery. So this is a representative case, which we have done here in our hospital. So this is a young gentleman who came with a testicular discomfort on the left side. Doppler ultrasonography showed multiple dilated channels in the left pampimum plexus, which showed a reflex on valsalva maneuver. So we took him for an angio. Here we can see this is a left renal vein, and we did an angiogram, and the contrast got reflexed into the left internal spermatic vein, and the catheter was further advanced deep inside. We can see dilated tortuous pampimum plexus of veins in the left testicle, which was embolized with the coils. So we usually embolize the varicoceles as a sandwich technique. We inject sclerosant and then followed by the coils. So we usually bridge the coils right from the iliac crest till the level of the entry of the, just about the proximal junction of the renal vein, so that the whole venous system get embolized and there won't be any recurrence of collaterals. Coming to the next domain, transjugular intrahepatic portosystemic shunt. This is nothing but creating a stent shunt between the hepatic venous system to the portal venous system to manage the complications of portal hypertension. So what are the indications and the contraindications? Indications: patients who have refractory ascites, who have refractory acute variceal bleeding, and to prevent any further episodes of variceal bleeding, we can do this stent. And absolute contraindications are patients who have congestive heart failure, severe TR, and pulmonary hypertension, because we are going to divert the blood flow from the portal vein into the systemic circulation, which is going to increase the preload to the heart. So relative contraindications are patients who have hepatocellular carcinoma and hepatic encephalopathy and thrombocytopenia, which we usually correct it. So we always gauge the patient with a modified MEL score. If the modified MEL score is less than 18, they are the right candidates for dips and tips. If the modified MEL score is more than 18, then they have a high risk of 3-month mortality post-tips. So let us have a look at the representative case. This middle-aged female who came with complaints of menorrhagia for last 6 months. She had ascites and bilirubin was increased. CCT scan showed there was an enlarged liver with a cardiac lobe enlargement causing extrinsic compression in the IVC. So this is an angiogram of the IVC showing there is an extrinsic compression in the intrahepatic segment with the collaterals in the hemiazygous channels. So what we did is we created a shunt between the IVC and the portal vein. So this is a TIPS needle. This is nothing but the needle within the catheter. So we went through the jugular axis, went into the IVC, then punctured under ultrasound and fluoroscopy guidance into the right portal vein. This is a catheter advanced into the portal vein and the angiogram showing the portal venous radicals. Followed by the tract was dilated with balloon, and the tract was measured with the measuring pigtail, how much length of a stent we need. Then followed which, this is a hybrid stent. So the tract will be caged with the covered stent, and either side of hepatic vein and portal vein will be covered with the bare metal stent. So that this is the post-dips angiogram showing the contrast flowing through the dip shunt into the heart. Coming to the next domain of procedures. This patient is a known case of CA cervix. She underwent surgery and radiotherapy. She was doing well for 6 months. After that, she started to have a unilateral pedal edema. Ultrasound scan showed only the subcutaneous edema, nothing much. So then CCT scan was done. There were a few nodes in the retroperitoneal region, the para-aortic nodes with the fat stranding, and we were seeing the right internal iliac vein, right common iliac vein, internal iliac vein, whereas on the left side we are not seeing the left side we are not seeing the left common iliac vein. We thought it to be a May-Turner syndrome, or it may be a lymph node which may be malignant, and it is causing the extrinsic compression. So what we did, we took her for the angiogram. We punctured the left common femoral vein and we did an angiogram. And this is the abrupt cutoff at the level of the common iliac vein. And these are the ilio-iliac collaterals, so that the collateral veins are draining to the contralateral side, and there were abdominal wall collaterals. So this was crossed with the guide wire, and the stenting was done. So this is a post-stenting image. Here we can see the good flow of contrast across the stent in the IVC, and the collaterals were completely vanished. Ilio-ilial collaterals and abdominal wall collaterals have vanished. So this is central vein stenting. So this was one of the interesting cases in my archives. This patient presented to the ICU with pancreatitis and in the midnight, and one of the residents has placed the central venous catheter, and next day morning they shifted the patient for CT abdomen to evaluate the severity of pancreatitis. In the plain scan, we found something bright in the IVC. So we were wondering what it is. So then we looked at the chest X-ray image, So there was a central venous catheter, but the down there was nothing seen. It's all blushed, probably because of the underexposure of the X-ray. So then we looked at the CT topogram. Here we can see the nice line guide wire dragging till the level of the right common femoral vein. So this, we took up the patient for angio, accessed the contralateral femoral vein, went in with the gooseneck snare, catched the wire, and then the wire was percutaneously removed. So this is a foreign body retrieval. Like this, we can retrieve dislodged catheters, the wires. So we have the hardware to remove it. Coming to the next domain, the IBC filters. So we all know we generally use it for deep venous thrombosis and to prevent the pulmonary embolism. Patients who have contraindication to anticoagulation or complications of anticoagulation, we deploy the IBC filter. There are classic indications, extended indications, and prophylactic indications for the utility of IBC filters. We generally place these filters in the infrarenal segment so that the chance of renal vein thrombosis is less. Whereas there are indications for placing the filter above the level of the renal vein. If there is a renal vein thrombosis or gonadal vein thrombosis, or it's a variant anatomy in the IBC, or there is a malignancy in the pelvis, we opt for a suprarenal segment to be placed. Contraindications, really, there are no absolute contraindications. If there is a sepsis or coagulopathy, it's better to correct it and put the filter in. So a representative case, this patient came to us with a huge right renal mass extending into the right renal vein and the IBC. There was this is a right renal cell carcinoma with a tumor thrombus in the IBC. Patient has been planned for surgery. So before going for the surgery, it's better to put a filter in so that the chance of pulmonary embolism is less. So took him with the transjugular approach, catheter in the IBC, angiogram showing the tumor thrombus. Then followed by, we have cannulated the hepatic vein to mark the confluence of the hepatic vein so that we don't place the filter till the level of the hepatic veins. So this is how the filter gets deployed. You can see the filter nicely getting deployed in the suprarenal segment of the IBC. And this is the final placement image. Okay. So then coming to, okay, we placed it, surgeon have resected it completely. The tumor is out. Now the filter also has to be out. We cannot keep the filter unnecessarily inside. So this, we can see the surgical staples. This is a filter inside. So then gooseneck snare has been used to hook the filter and the filter has been removed. So this is how the filter looks when it comes out. This is a tumor thrombus which has been catched in the filter, which prevented the major event of pulmonary embolism during surgery. So coming to the last domain of the procedure variety we are going to see today is catheter-directed venous sampling. This is a gold standard for localizing endocrine disorders. This helps us to localize the abnormal hormone secretion if we are not sure whether this particular gland is secreting or something else is secreting, ectopic secretion is there or not. It helps us to further manage the patient, strategize whether to go for medical management or surgical management. The common sampling we do is adrenal venous sampling and inferior petrosal sinus sampling. So let's have a brief look at adrenal venous sampling. This is a non-invasive workup protocol we employ for adrenal venous sampling. Once we come to either a CT or MRI imaging, if there is a suspicion of malignancy, they always go for adrenalectomy. If there is no suspicion of malignancy, then the role of adrenal venous sampling comes. So we do it to lateralize the tumor, whether it is secreting from the right side or left side. If it is unilateral, then the surgical approach has been opted. If the secretion is from both sides, then it has to be medically managed. So this is an example case. This patient came to us with a left adrenal gland lesion, which is hypoenhancing, and the bulky right adrenal gland. So there is a lesion on the left side and there is a bulkiness on the right side. So we are not sure whether the hormone is secreting from both sides or the left tumor is actually functioning or not. So for confirming, we took him for the adrenal venous sampling. So the right adrenal vein always drained directly to the IVC, whereas the left adrenal vein drains to the left renal vein and then goes to the IVC. So this is a femoral approach. We went in with the curved catheter and hooked the right adrenal vein. Now super selectively, we catheterized the right adrenal vein and took the sample, followed which we cannulated the left renal vein, then the left suprarenal vein, and the sampling has been done. And this patient actually had a secretion from the left side and he went for surgical management. Coming to the next sampling, which is petrosal sinus sampling, this is a non-invasive workup approach for Cushing's disease. So when we do the non-invasive testing of high-dose dexamethasone, CRH stimulation, and if MRI is non-conclusive, we still have a mixed response, then we go for inferior petrosal sinus sampling. So this is a representative case. contrast enhanced MRI has been done, there was a hypoenhancing area on the left side of the pituitary gland, which was not enhancing even after 15 minutes of contrast administration. So it means usually if there's a functioning gland, we tend to see some amount of enhancement in the delayed phase images, whereas this patient didn't have any enhancement even after 15 minutes. So we really doubted whether the secretion is from the pituitary or there is any ectopic secretion of ACTH. So we cannulated the petrosal sinus. So before doing, we usually go on for a MR venogram to look for any variations in the cerebral venous anatomy, because petrosal sinus is one dural venous sinus which may have normal variants. So we always check in MRV, then go on for the procedure. So we cannulated bilateral IPSS and the sampling has been done. And this patient actually had secretion from both sides. So the hormone was getting drained on both sides. So they confirmed that the secretion is from the pituitary and the patient went in for surgery. It's the last slide. So I'm sorry, I took a bit of time to explain about the spectrum of procedures. There are plenty of variety of procedures. I just gave a pinch of salt about the spectrum. The other scope of IR procedures or hemodialysis access interventions, DVT thrombolysis, chemo and radio embolizations, microwave and radio frequency ablations, and endovenous laser ablations and pain management, and much, much more. And thank you all for a patient listening. And I especially thank Dr. Naja and Dr. Qasim and all the dignitaries for giving me this opportunity. Thank you. Thank you so much.
Thank you, Dr. Muthu, for showing us a wide spectrum of interventional radiology procedures and showing us how interventional radiology procedures can be useful in different clinical spectrum. I'm pleased to now invite our next and final speaker, Dr. Nabil Al-Safai. Dr. Nabil Al-Safai is a consultant neurosurgeon and spine surgeon at Bahrain Specialist Hospital. He is also chair neurosurgery section, consultant neurosurgeon and spine surgeon, Department of Medical Affairs, Royal Commission Hospital, Jubail Industrial City, Kingdom of Saudi Arabia. He is also director of Saudi Neurosurgery Study Workshop, Saudi Association of Neurosurgical Society Academy from November 2018 till date. Dr. Nabil Al-Safai will be speaking on the impact of interventional procedures on neurological patients. Please welcome Dr. Nabil Al-Safai.
Bismillah ar-Rahman ar-Rahim. Good evening, everybody. I feel like I'm the only reason why you're still here now, because I'm in the last lecture. So everybody is eager for me to finish and head his way. Is there food or? Yeah? Okay. Well, that makes it even more difficult, because that means that I have to make you hungry and starving. Until we start the slides, I just want to thank you very much for your kind invitation. And I am very impressed today by the value and the level of the lectures. Excellent work and excellent clinical practice. Secondly, I have been impressed by many of you as I have been working with you in BSH, and I'm very proud to be associated with you. Okay, Bismillah ar-Rahman ar-Rahim. I think the first thing I wanted to say is there is a new beginning here, and the beginning is a collaboration between the Neurosciences Center, the NS Center, with BSH. And I believe that with collaboration and exchange of knowledge, we would love to practice neuroscience with a high standard and critical analysis of ourselves, and have your help in trying to elevate the way we manage our neuroscience patients. So I'm really looking forward to this. The impact of interventional procedures on neurological patients, I have to give a disclosure. I'm not an interventionalist. I am a neurosurgeon, and I cannot teach you, but I can try to entice you to understand this area. I have a subspecialty in spine and skull base, but I worked and I trained in a center of excellence in cerebrovascular, and I saw all kinds of cerebrovascular cases during my training in Toronto. Neuroservices are very, very, there's so much. People think neurosurgeons only know little things. In order to be competent, we need to know a bunch of things, as you can see in the slide. And cerebrovascular is actually one of the things that we will discuss today with an interventional edge. Let me share with you this. I'm not sure if you can hear it, but this is a well-known Turkish singer. Can you hear the audio? Yeah. So it's not going to be long. I'm not going to bore you with Turkish music. But this musician was rehearsing. And while she was rehearsing, she suddenly felt the worst headache in her life. Look at her developing a seizure in front of public, and then suddenly she collapses. This is true. This is real. This is subarachnoid hemorrhage from aneurysmal rupture. And when you see it, it's real. It is there, but we are not very aware of it in the public because many of these patients do not reach the hospital soon enough, especially in this part of the world. This patient ended up having surgery by a colleague, and she had the aneurysm. You can see the angios and everything, and then she came back with a big bright, and she was singing. And this is the beauty of doing this specialty. So what to evaluate when you see aneurysms? Everything that will determine management, we need to look into the aneurysm. If it's ruptured, do we need to clip it or do we need to coil it? And if it's unruptured, should we even do anything and just watch it or clip and coil? I have been involved in 2015 publishing a bunch of papers about this, looking at the global differences in management surgically versus interventionally. And definitely there is a big surge of intervention. Intervention is the way to the future, but you cannot let surgeons stop because there will always be a group of patients that require surgery. So we cannot say that surgical approaches to aneurysm will stop, but we can always use and benefit from intervention. So educating and looking at the different caveats of imaging is very important. When we talk about imaging, let's look at this. We look at the CAT scan of the brain, and then we look at an angiogram, and you wonder where the aneurysm is. Sometimes you have multiple aneurysms. You cannot treat all the aneurysms in one shot. You know, there are algorithms for asymptomatic aneurysms. But you look at the pattern of bleed, and when you look at this, it's in the interhemispheric fissure anteriorly, so you get suspicious that this might be an ACOM aneurysm that has bled. So when we look at aneurysms, we look at specific criteria, and it's not easy. But what I would like to do is show you some of the things we look at to make a mature decision. We look at the localization, the configuration, the circumstances the patient arrives with, whether they bled or whether they have hydrocephalus or they have an underlying disease like familial disease or they've been radiated, etc. Whether the vessels are diseased because they're elderly or they've been radiated, and if the patient is young or old, and what is the etiology. So I think I have lots of slides on that. So I will just go through some of them and then head towards dinner very quickly. The first thing is that this is a bifurcation aneurysm of an M1, which is a middle cerebral artery. And you can see the angio and you can see the view in the OR. That's how it looks in the OR. This is the star is where the MCA aneurysm is. Looking at the location is very important. Basilar tip aneurysms historically were treated surgically, but now they are very risky surgically, and we tend to try to do them interventionally more often than other sides of aneurysms. This is a posterior communicating aneurysm. Would you clip it or would you coil it? In this instance, clipping. On Monday, BSH will have the first aneurysm that is a PCOM aneurysm coiled, and we will have a team. I will be a backup as a neurosurgeon, and we will have Dr. Mudassir helping Professor Timo Krings, the chairman of the University of Toronto, in doing the first PCOM aneurysm coiling. This is a carotid tip aneurysm. So location. When we look at the configuration, we need to look at the direction of the aneurysm, the neck of the aneurysm, the width of the aneurysm, whether it's in a sidewall or in a terminus, what is the size of the aneurysm. 7 millimeters seems to be a magic number, and it happens to be my lucky number, by the way. And also the shape of the aneurysm. So all of these things, we look at all of these things, and we try to determine whether this one should be coiled or clipped. When we look at the direction, you can see at the arrows pointing at the aneurysm and looking at its direction. ACOM aneurysms, if they are pointing upwards, away into the brain, and backwards into the ventricles, will be very hard for a surgeon to put a clip at its neck. When it's pointing downwards, means when I come and operate this way, I'm at the bottom of the brain, and it's pointing anteriorly, means it's just looking at me, begging me to clip it, I'll clip it. So you start deciding when do you want to coil and when do you want to clip based upon the direction. Also, if there is a vessel at the neck, as you can see here, then you probably will hurt this vessel. Versus if there are surrounding perforators, then you better not clip this, and you better coil it so that you don't hurt the perforators. A narrow neck would be very nice aneurysm to shove in lots of coils in it. A wide neck will require more modifiers and more instruments to do it. And the features keep going on. I really, I know you are not neurosurgeons, but we also even look at the angle. Look at the angle of the aneurysm to the parent vessel. And intervention, one of the things that the intervention has introduced to us, a challenge, is that it makes the tree different, because it just changes the tree of the vessels and the hemodynamics change. And that is a challenge that we have to look for different hemodynamics and maybe future aneurysms coming out with intervention. Whether the aneurysm is in the terminus or in the sidewall, whether it's big or small, and the shape of it, if it's bilobed, if it has a daughter aneurysm, and the timing of filling, if it fills slowly or fills quickly. We look at all these caveats and we make a decision, a mature decision, whether we should go for coiling or surgery. When you have a blood clot, it just takes you towards surgery. I mean, you're not going to leave a blood clot and start coiling. You need to decompress the brain. And when there is hydrocephalus, sometimes doing the surgery helps alleviates the intracranial pressure. Whether you put a ventriculostomy, or you go like here in the lamina terminalis and you open up the space, opening up the ventricles, CSF gushing extra cerebral, and so on and so forth. So I think I want to move on to this topic. This is when you have multiple aneurysms in a patient and you wonder which one bled. For us, we look at the interhemispheric anteriorly, fissure anteriorly. We see a lot of blood. We say this is an anterior communicating aneurysm. We look at this, we see a lot of MCA, Sylvian fissure blood. We say this is an MCA aneurysm. We look at something a little bit challenging, like this one, when you have a lot of blood in the Sylvian fissure and a lot of blood around the brainstem where the PCOM is, and you wonder if it's what it is, and it's an ACOM aneurysm, and it's so on and so forth. We'll move on to the next thing I would like to discuss. One of the things to discuss when you are dealing with a ruptured versus unruptured aneurysm is to see, is your procedure risky? For us in neurosurgery, we give an estimate of 10% risk of procedure. So when you put a balance You look at the size, the localization, if there is any other rupture, the life expectancy, and all the things I've mentioned. And you try to see, is the balance going to go towards the 10%, one time, one risk during the procedure, and then you save the patient of having any rupture in the future. Is it worth it? And if the risks are more than what the natural history will give you, then you advise the patient not to do anything and let's observe. If the balance goes the other way and the risk of rupture is more than the one-time risk you are going to take for surgery, then we recommend surgery. So this is how we think. It's very exciting. There is a lot of research in robotics for interventional and endovascular procedures, and this is actually taking a steep at different subspecialties, including neurointerventional.
Now
This is another video.
Everything.
Dad, side of your face is drooping. Mom,
Probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Gracie, call 911. Honey. Tim.
You need an ambulance to come for
Tim.
So this guy is having a stroke, right? So, they did the right thing. When you want to deal with acute stroke, you need a team approach. You have to have a workflow for acute stroke. So you need to have a proper way of educating people so that you can detect the disease. You need to have a way to transfer this to a stroke center. And you need to have an excellent stroke center to deal with this. And I think BSH is becoming one of the stroke centers that will be probably the only one in the private sector. So congratulations for that. Medical evaluation is important. Imaging is important. Acute treatment is important. Post-operative management, whether it's interventional or surgery, is important. Rehabilitation is important, and prevention is important. All of these things are very necessary, and they require expertise. When you're dealing with an acute stroke, you require an interventionist and neurosurgeon. When you're dealing with stenosis, whether it's extracranial or intracranial, you would need a neurosurgeon. And if it's a carotid, maybe a vascular surgeon can do that. When it's a bypass, you would require a neurosurgeon to do that. And endovascular thrombectomy, and I'm sure Dr. Mudassir can give volumes of speech about that, is exactly a procedure that is summarized beautifully in this video. I'm avoiding going through a lot of algorithms and stroke management stuff because I think I just want to highlight certain specific things. And you can see there are different companies and different ways of doing this, but this is the bottom line. And see how you bring in this mesh and just pulls the clot all the way out beautifully, and then you get excellent results. And most of the time, the overall treatment effect is really good. So proximal occlusion, large clot burden. Let's go through a case. A 62-year-old arrived after 4.5 hours. You start IV thrombolysis. No clinical improvement. NIHSS is 18. You do a CT scan, you don't see anything. You do perfusion, you see that there is a right MCA infarct. This would be different than the patient I just saw in the video. That guy had a left MCA infarct, weakness on the right side, and dysphasia. You look at the angio, you see that there is an occlusion. You do the procedure. This is how the catheter looks. And you do the procedure beautifully by Dr. Mudassir, and then suddenly you have a very nice arterial tree. So You need to do this, and it's very important. When you look at the Canadian statistics, and I don't have the Bahraini statistics, you would notice that stroke is the third leading cause there. I probably it is the fourth year after motor vehicle collisions and car accidents. I almost had one coming from Saudi. 50,000 stroke occur in Canada each year. 300,000 Canadians are living with the effect of stroke. 2.7 billion Canadians dollars are being spent per year. 15,000 TIAs per year reported in Canada. Population Canada is 30 million. So we can make a division and see what would be the percentage. It's still very high, maybe 2,000 to 3,000 per year here. Don't forget, we enjoy the luxury of the rice and the meat and the luxury of the burgers and the Kentuckys. So we've doubled our percentages here. So when you have carotid stenosis, it is amazing. I was looking into this a while ago, and I had this slide a long time ago, looking at the history of how do you treat carotid stenosis. In the 1950s, nobody had any idea. In the 1960s, a new operation called carotid endarterectomy came up. People were so excited. So they were doing the surgery in the neck in order to make the carotid artery wide again from the stenosis from the fat and the plaques. 1970 surgery is a terrific idea. In the 80s, the studies were going the other way around, and they said it's very dangerous. In the 90s, came back again, and they said it's very effective. Depends upon the publication and how people publish it and their outcome perioperatively. In 2000, angioplasty and stenting, which is less invasive, came up. 2010, confusion, not sure what to do. Now, 2020, you decide. You look at the literature and you decide. So it's very funny how we went up and then we went down and then we went up and then we went down. God knows what's going to happen in 10 years. But I think stenting has a place to stay. And that's why I put this disease in this lecture. So detectable stenosis in patients more than 65 years old, 75% of men and 62% of women. So if you have patients who are more than 65 years old, this is what you're going to have. Severe stenosis, not just detectable, but severe stenosis, meaning 75% or more, will be in about 2.2% and 1.1% in women. So how many are we here? Do we have 100 people in this room? Watch out. There are 2 men here who have it and one woman who has it. I wonder who it is. Watch out. Be careful. Carotid stenosis and risk of stroke. Asymptomatic carotid stenosis risk for stroke. Look at the percentages. The more the percentage of stenosis is, the more the risk of stroke per year. But you are at higher risk if it's 75 to 94% than if it's more than 95%. And when you go to occlusion, the risk goes down. That's why we don't treat occluded arteries. When it's occluded, khalas, it's done. What's done, it's done. So this is important to realize. And there are different ways of imaging it: CTA, MRA, and screening by ultrasound Doppler. And it depends upon your MRI technologist. If they have very excellent technologists, you can actually do amazing images and look at the wall. The wall is very important to look at as much as the lumen. That's why I put 2 slides, one showing an intraplaque hemorrhage and the other one showing an ulceration. It's very important for decision-making in management. So comparing carotid endarterectomy and stenosis, there has been so many trials. There are 12 trials that I think are very good trials, and 6 of them are excellent and significant, and their names are here. And as you can see, these trials have a lot of interesting names. Sounds to me like food because I'm getting hungry. Sapphire and Eva and Space. But these trials have gone through a lot of studies and looking at different categorization of patients. And CRIST, which is a really, really favorable study that compares endarterectomy with stenting, has shown interesting results. And I think they are comparable, and you need to know the expertise. Do you have an excellent surgeon or an excellent interventionist? So you would prefer to give it to an experienced interventionist to do a stenting if he has better outcomes than the interventionist, and vice versa. But generally speaking, they are more or less similar. And when you look at the graph, surprisingly, it is safer to do a stent for a younger patient with a stenosis and to operate on an older patient with stenosis. So that I think that's interesting, and that's what we do. We do carotid arterectomies in patients in their 70s and 80s, and we rather stent patients who are in their 50s. And that was one of the conclusions of CHRIST, and there's a lot of details. But contraindications to endarterectomies are always reasons for you to do the stent. Like if the patient had a previous surgery or an irradiation for cancer, thyroid cancer, whatsoever, if the lesion is not accessible surgically, if there are long segment of stenosis, so you cannot just go all the way up and down to dissect the carotid artery, if there is a hyperacute stroke, and if there is a dissection, because you're gonna make things worse. And you do a stent and put it, and then yuppie, yay, Canadian style, yay, looks so much better, looks amazing. I had a case of a 79-year-old female, right-handed, retired librarian with congestive heart failure, medically controlled, and had a bilateral carotid stenosis, left more than right, detected when investigated for cerebral aortic stenosis. And 15-minute episode of left monocular visual change, which resolved, but no change in vision now. And we looked at the images, and we see clearly there's a right internal carotid occlusion, so you don't do anything to these, and a severe left carotid stenosis. And these are the questions we ask ourselves when we see these patients. Do you want to do a left carotid stenting? Do you want to do a left carotid arterectomy? Do you just want to do best medical treatment, or do you want to do even a bypass for the right occlusion? In reality, and I think I gave you the answer already. In reality, the statistics say that only 33% of our surgeries are appropriate, and almost half of our surgery are uncertain. That's what the literature when dissecting the thing on the ground, and maybe 18% are inappropriate. There's a bit of, is there a vascular surgeon here? Raise your hand. Vascular surgeon. Yeah. So there is a bit of fight between neurosurgeons and vascular surgeons. Thank God they're not here, so they didn't fight me and I'll win the fight. They tend to operate with moderate stenosis. We tend to operate with only severe stenosis. So we feel that their threshold is lower than ours, and they feel that we just let some patient go. The bottom line, if your risk factors as a surgeon are not less than 3%, please don't operate on these patients. The risk factors for angiography, Dr. Mudassir, is 1.2% probably, right? For angiography. So 1.2% for angiography, plus whatever your risks in your hands are over the past 5 years doing the procedure. If they are more than 3%, give it to the surgeon. This is a patient who came with a stroke and has midline shift and a swelling and deteriorating, decreasing level of consciousness. So they come and call us and they say, what do you want to do? This is a patient that needs to be intervened. And one of the things that we can offer them is hemicraniectomy. There's no place for interventional at this stage. And that's what we do. We do a hemicraniectomy in order to decompress the brain and let the brain herniate outwards instead of herniating inwards and pushing on the brainstem. And there are lots of studies that supports doing this early before the patient deteriorates, can give them a better Rankin score and a better outcome. But being a little bit late and doing the surgery, you make the patient end up being a vegetable. So that's why it's very important. But at this point of time, there is no interventional procedure for this. And the best scenario is to have to look into all the things that I mentioned in this slide. The last thing I want to talk about is, I'm sure, I hope I'm not, I haven't taken too long. Bypass to revascularize the brain. There is some, the value of revascularization is to augment the flow, which is on the left side, or to preserve the flow, which is shown on the right side. You want to enhance the flow because there is moya disease or obstruction proximally. So you're trying to enhance the collateralization by doing maybe a direct bypass surgery, or a flow preservation in the left by doing an interventional procedure or an open procedure. The procedures that are there, this is showing the collateralization and the cerebral blood flow, volume and flow, stuff that are boring, but I love so much. And the revascularization, there is direct revascularization when you do end-to-end or end-to-side anastomosis surgically. And that creates a flow to the area that is ischemic, or indirect surgical approach when you would do an arteriosyngiosis or encephalomyosyngiosis or a durosyngiosis. And these are all surgical procedures and can be also substituted, I think, very soon with interventional procedures. So in conclusion, neurosciences is a whole big department, is a whole big book of disorders. And neurosurgeons need to be excellent physicians in order to help their patients. We need to know about medicine, we need to know about general surgery, we need to know about radiation, we need to know about a whole lot in order also to do the proper consultation. And it is very exciting for me to be in front of you to tell you this, and hopefully work side and side with you, hopefully forever. And I am very proud that this year we are going to start, and we kind of started, we had a soft start of our neurosciences department. And I think the names mentioned here, I think Dr. Mudassir is here. I haven't seen Mahmoud. He's not here. So, and there is Dr. Mohammed Al-Matri and Dr. Tariq. Soon you will see, he had his NHRA license. And we are very, very happy to work with you. So thank you very much for the opportunity, Dr. Qasim and Dr. Naga.
Thank you for all the doctors who presented on stage and shared their knowledge. So before we enjoy the food, finally, I'd like to ask Dr. Najah and Dr. Qasim to come on stage to deliver the appreciation mementos for our speakers, moderator, and panelists. I would also like to ask Dr. Adel Khalifa to come on stage, Dr. Mohammed Balghith, Dr. Abdulaziz Hassan, Dr. Mutu, and Dr. Nabil Shafi. We were very honored and grateful for having you all here. You can enjoy the food near the entrance to your left side. Thank you all.
I just want to mention, we did not have a chance to have the question and answer session, but I'm sure all the speakers will be very happy to answer your questions directly whenever you have a chance to see them. Thank you all for attendance. Thank you.